When to start? Upadhyay sir.
Sir,
Conference चालू sir. Could we start sir? Upadhyay sir.
Namaskar and good afternoon to all.
Good afternoon, sir.
State Institute of Health and Family Welfare, we welcome Dr. Gaurji and team from Sri Rajchandra Mission for the participation. The RBSK cell of Gandhinagar, Ministries of Government of Gujarat, and all the participants from various institutions. We have formally
Thank you,
begun
sir.
the webinar. Just to tell you in short, Shrimad Rajchandra Mission, I think all of us must have heard about it. It's a Dharampur based spiritual organization running on ideals laid down by the Saint Shrimad Rajchandra. One of the many philanthropic activities of Shri Rajchandra Mission is running a hospital in Dharampur. One component of this hospital is neonatal intensive care unit. As we generally know is that SNCU, all of us must be aware that about 25% of babies graduating from SNCUs in practically all parts of India have got some or the other developmental delay. So Srimad Rajchandra Mission, SNCU has an attached early intervention center which starts early identification and early interventions right from the place of SNCU of the newborn. They have done a pioneering work in that. There are various departments working in this district early intervention sector, that is physiotherapy, occupational therapy, hearing screening and early intervention in hearing, visual screening and early intervention in the form of prevention and treatment of ROP, congenital cataract. They have got a rehabilitation center, and with the help of other institutions, they are correcting various congenital malformations also. They have got a speech therapist and counseling by experts. This center has been identified as one of the pioneering centers of Government of Gujarat's SNCUs and DEICs. They regularly do trainings of DEIC staff of Government of India, Government of Gujarat, as well as other states. Today we will discuss about the role of physiotherapy with SNCUs and SNCU graduates. I'll now lay the floor open to Dr. Gaurji Hood, who has done his MD in PSM, is a consultant community physician, public health specialist, and head of the district early intervention center at Dharampur. His areas of interest are maternal and child health, preventive promotive healthcare and epidemiology. Now he will be the one who will be handling the whole of scientific session from Srimad Rajchandra Mission, Dharampur.
एक इंट्रोडक्शन फ्रॉम स्टेट लेवल आरबीएस के सेल आल्सो साहब.
Yes, please go ahead, sir.
Good afternoon. Dr. Rathod here, State Nodal Officer for RBSK.
डॉक्टर प्रद्युमन सिंह राठौड़, कंसल्टेंट आरबीएसके.
All the respected seniors, all the participants. આપણે એક જાણીએ છીએ કે અત્યારે જે મેડમ જે છે પ્રિન્સિપલ સેક્રેટરી મેડમ એમનો ક્લિયર કટ ઇન્સ્ટ્રક્શન ગાઈડલાઈન છે કે જે આપણું એસએનસીયુ છે, એનઆઈસીયુ છે એની જે સર્વિસીસ છે અને આરબીએસકે ની સર્વિસીસ છે એનું કોઓર્ડિનેશન પ્રોપર થાય. મેડમને આ ખાસ એમને સૂચના દરેક વખતે ડીઆરએમ માં મળતી હોય છે, એમના ઇન્સ્ટ્રક્શન હોય છે. ઇવન 1000 ડે આપણે જે છે ક્રિટિકલ એના પર બી મેડમનો ભાર હોય છે અને ધીસ ઇઝ ઓલ ધ પાર્ટ ઓફ ધેટ. આપણે એને એ સંદર્ભે અહીંયા મીટિંગ રાખેલી છે કે જે આપણે આરબીએસકે અંડર આરબીએસકે જે સર્વિસીસ છે આપણે પ્રોવાઈડ કરવાની છે 0 to 18 યર્સના બાળકો માટે, એને એનઆઈસીયુ અને એસએનસીયુ જોડે કઈ રીતના વ્યવસ્થિત કોઓર્ડિનેટ કરી શકીએ અને બાળકોને બેટર સર્વિસીસ એમને બેટર લાઈફ આપી શકીએ. એટલે મેન આજે આપણું જે છે શ્રીમદ રાજચંદ્ર, આપણે જે આપણું ડીઆઈસી રિલેટેડ અને પછી સેકન્ડરી ટર્સરી રેફરલ સર્વિસીસ ને બધી જ છે. તો ત્યાંથી સરે જે ઉપાધ્યાય સરે વાત કરી છે એ રીતના શ્રીમદ રાજચંદ્ર આપણને ઇન ડેપ્થ બધું એ માહિતી અને આપશે, આપણને એનાથી માહિતગાર કરશે, વિલ પરકોલેટ કે એકોર્ડિંગલી આ રીતના થઈ શકે. એટલે એક અત્યારે આ ઇનિશિયલ પહેલા ફેજ પર મેડમની સૂચના અન્વયે તમામ આપણે ડીએઆઈસી છે, એસએનસીયુ જેટલા બી છે એક્રોસ ધ સ્ટેટ, એનઆઈસીયુ, એસએનસીયુ, ત્યાં વર્ક કરતા આપણે પીડિયાટ્રિશિયન સીઓ છે, ફિઝિયોથેરાપિસ્ટ આપણા ડીએઆઈસી ના છીએ, ડીએઆઈસી ના આપણે મેડિકલ ઓફિસર્સ જે છે એમને તમામને હાજર રાખી અને એક વર્કશોપ આવી રીતના વર્ચ્યુઅલ મીટિંગ કરવાની સૂચના આપી હતી અને એના ભાગરૂપે આ મીટિંગનું આયોજન થયેલું છે. એટલે ફરીથી સ્ટેટ તરફથી અધિક નિયામક પરિવાર કલ્યાણ ઓન બિહાફ ઓફ એડિશનલ ડિરેક્ટર ફેમિલી વેલફેર હું તમામને આવકારું છું અને ઇટ્સ ઓવર ટુ શ્રીમદ રાજચંદ્ર ગુરુજી.
Yeah.
અને એક એડ ઓન કરવા માંગીશ કે this is a first we have just mentioned the subject like orientation because this is a first time. So આ ઓરિએન્ટેશન છે, ઓરિએન્ટેશન પછી જ્યારે આપણે એક ટીઓટી કરીને એક ટ્રેનિંગનું પણ આયોજન કરીશું, બટ એકવાર પહેલા ઓરિએન્ટ કરીએ અને કેવું એનો ઇમ્પ્લિકેશન છે એની ઉપર પછી નેક્સ્ટ ટાઈમ ટ્રેનિંગનું પણ આયોજન આપણે ધરમપુર કાં તો વડોદરા એસએડબલ્યુ ખાતે આનું આયોજન કરીશું.
Yeah. So,
Please take further.
yeah. So first of all, very good afternoon to all from Shrimad Rajchandra Hospital and Shrimad Rajchandra District Early Intervention Center at Dharampur. So good afternoon once again to all, and we would like to thank and express our gratitude to Government of Gujarat, especially the Health Department, Commissioner Ma'am and Principal Secretary, now she has become Dr. Rathod Sir, Pradyuman Bhai and SIHFW, and especially Dr. Akshay Upadhyay Sir for letting us give the opportunity to share our knowledge and experience. So we have right now our whole team, but they are percolated at different places. So Dr. Tina Ben Mehta, she is one of our trustees. She is also there at DIC Dharampur. You can see in that slot. So she's there with our presenters for today, who are there at the ashram at Dharampur only. And Dr. Yogendra has also joined. He's our pediatrician. So, but during the course of our sessions, we'll get to know that what our team does and what is the different kind of work we do. So first of all, as per the guidelines of the principal secretary, we have organized this today's sessions in 4 different groups. The first thing will be the self-regulation of babies. Like self-regulation માં શું થાય છે અને આપણે કેવી રીતના કરવું પડશે બાળકોને. So on that, Dr. Payal will be presenting the thing. The second presentation will be on the second presentation will be on neuroplasticity, that what neuroplasticity is all about, and Dr. Neha will be presenting on that. The third will be on epigenetics by Dr. Bansi, and the fourth one will be the role of the team members in the NICU, that I myself will be presenting. So first of all, we'll start up with the session of self-regulation in newborns. The presenter for this topic is Dr. Payal, and she is a certified pediatric physiotherapist, and she has done her courses from USA, Carolina, and she is also an expert in aquatherapy from Switzerland, and she is blessed to be a part of the missions over the last 14 years, and she's the trainer for even all our DIC માંથી બધા આપણે ત્યાં આવેલા હશે વર્ષ 2 વર્ષ પહેલા ધરમપુરમાં, so you must have met her and she must have interacted with you. So now I would like to hand over the the session to Dr. Payal to take self-regulation in newborns, and what is the importance and what is the role of each member for that. Thank you. Your voice, I think you have to unmute.
Yeah.
Yeah.
That's right. Thank you, Dr. Gauraj, and thank you, everybody. Hello, Dr. Akshay Upadhyay. How are you doing? So we'll just start quickly. So as you can, so we're just starting with a small video. The people who have come here know that we always talk through videos. So it's a very, it's going to be very nice to see 2-3 videos in the start, and then we'll discuss further. Okay, so we'll just start with a video. Just do your observations and let's see what we can discuss after that. Okay.
Ma'am, actually we cannot see video.
So we'll just discuss it. Just let whoever can see it right now. Just hello.
Yes, ma'am.
Yeah, is the video is not visible at all?
No, ma'am.
You can hear me, madam.
It's visible.
Is that the case to everybody that nobody can see the video?
No, it's visible.
It's visible, right? So we'll just
Visible,
wait.
madam, visible.
The people who can't see it, we'll discuss it anyway. Okay. So for the people who can see it, let us just continue. All right. Okay. So just okay. So we'll just wait for the video. And yeah. It's good. Okay. All right. So this is the first time we're playing the video. Sorry for the inconvenience. Because so what we just saw, just to brief for the people who could not see the video, we saw a child showing tantrums. Okay, so this child had a huge difficulty to come to the department, and also complained of a lot of tantrums at home. So we didn't know where the behavior was coming from, and after a thorough evaluation, we wanted to know what caused that behavior. Now, why are we talking about behavior here when we are talking about the NICU? આપણે બિહેવિયરની કેમ વાત કરી રહ્યા છે? કેમ કે આમાં ખૂબ મહત્વનું છે જાણવું કે આ ક્યાંથી આવ્યું છે. તો આજે આપણે જે કઈ રીતે શીખવાના છે હું તમને ખાલી એક બ્રીફ અપ કરું છું. You might find it a little different today because we are going to the root cause of a problem. Now, the problem in this is that we see a lot of these children coming to us either in our OPDs, or we have them complain about autism. We have them complaints of learning disability irritability in school, or we have them also having hyperactivity. એ બધું ક્યાંથી આવી રહ્યું છે? Where is the root cause coming from? એક જાણવું ખૂબ મહત્વનું છે. અને કોઈક વાર આપણે જો આજે સમજશું કે ક્યાંથી આવી રહ્યું છે, તો આપણને ખબર પડશે કે કઈ રીતે આ બાળકોને આપણે પહેલેથી, that is why we talk about early intervention, because આ લોકોને જો આપણે પહેલેથી આઈડેન્ટિફાય કરશું તો આ લાંબો પ્રોસેસ નહીં થાય એ લોકો માટે. They will not have to go only for such a extreme behavior. So we'll start with the presentation. If you can just start with the slides. With the third slide. All right. So there's always a reason to behavior. Now this behavior is something which we can prevent. Okay. Now we'll see that just go to the next slide. Oh, with my phones. Okay. Oh, it's the okay. So the next slide. All right. So just coming with few of the research that we have seen a focus on the self-regulatory mechanism, a focus on self-regulatory capacities may also be helpful, as there's some evidence that the kids which are born extremely preterm and low birth weight have difficulty with self-regulation, and the skills that affect that is because of that what happens is that executive functions એટલે શું, એ લોકોનું કોગ્નિશન છે કે એ લોકોનું કોઈ જાતનું સેલ્ફ રેગ્યુલેશન નથી થઈ રહ્યું એ બાળકનું. તો આ બધા બાળકો ક્યાંથી આવ્યા હતા? તો એ લોકોને કોઈક વાર એક્સ્ટ્રીમ પ્રીમેચ્યોરિટી હતી એઝ અ ચાઇલ્ડ, કે લો બર્થ વેટ હતું, કે એ લોકો બહુ લાંબા સમય સુધી અનવેલ હતા, કે એનઆઈસીયુની અંદર હતા. તો એ બધા બાળકો આગળ જઈને આ સેલ્ફ રેગ્યુલેટરી મિકેનિઝમ્સ નથી કરી શકતા. સો એટલે early deficits in the self-regulatory capacities have linked with the child disorders like ADHD, like oppositional disorders. તો એ બધા બાળકો માટે આપણે આજે ડિસ્કસ કરવાના છે કે સેલ્ફ રેગ્યુલેશન કેમ નહીં થયું એ બાળકોમાં. એટલે સેલ્ફ રેગ્યુલેશન શું છે એ ખૂબ મહત્વનું થઈ જશે કે આ બાળકો રેગ્યુલેટ કેમ નહીં કરી શક્યા હમણાં સુધી. તો કયા ફેક્ટર્સ છે કે જે સેલ્ફ રેગ્યુલેશનમાં હેલ્પ કરે છે? તો આ બાળકો જ્યારે પ્રીટર્મ હતા ત્યારે લોકોનું શું થયું કે એ લાંબો સમય સુધી હોસ્પિટલમાં રહ્યા. They were on a long term stay in the hospital. They had isolation, physical isolation from the because of the medical interventions, or they had less communication with their parents, or the impact on the parents was less. So એ બધાના લીધે that communication gap decreased. એ વજહથી શું થયું કે ડિપ્રેશન જે હતું મધરમાં, કે because of postpartum depression, એ બધા મધર્સને because of that it continued in the child. એટલે શું થયું કે બાળકને પણ ડિપ્રેશન આવ્યું. એટલે મધર તો કોઈક વાર પોસ્ટપાર્ટલ ડિપ્રેશનમાંથી નીકળી ગઈ, પણ બાળક તો હજી ડિપ્રેશનમાં રહ્યું, લાંબો સમય સુધી રહ્યું. એને લાગ્યું કે there is nobody to take care of me in this time. So this led to a problem. So now we'll just see another video of how babies learn how to cope up. So it's very important for child to learn how to cope up. Cope up એટલે શું કે એ જ્યારે કોઈ સ્ટ્રેસ આવે છે બાળક ઉપર, કોઈ સ્ટ્રેસફુલ સ્ટિમ્યુલાઈ આવે છે, કે કોઈ જાતનું હંગર પ્રેન્ક આવે છે, કે he is feeling that he is uncomfortable, he is in pain. So at that point of time, what to do to make the child regulate? How does the child learn to regulate it in its own self? So we'll just play a video of a normal child right now who has learned the pattern of self-regulation.
करो करो
So the, for the people who could not, so for the people who could not really see the video, a small baby, say around 3 months old, is doing a self-regulatory mechanism of putting the hand to mouth. Okay, it's very common to see kids doing hand to mouth, suckling on the fist, or coping up with behaviors where they know it will calm themselves on its own. So physiologically also it calms them off. So now we'll see that this child, as we saw, has this self-regulatory mechanism in which a stressful stimuli was there. એક સ્ટ્રેસ હતું એના ઓલામાં, એ વચ્ચેથી શું કરે છે કે ઈ સ્ટ્રેસ એને ભૂખ લાગી હતી બેઝિકલી. તો ઈ ભૂખ લાગી હતી ત્યારે એને શું કર્યું, એને ખબર હતી કે એવરી ટાઈમ મને ભૂખ લાગે છે આ 3 મહિનામાં હું જ્યાંથી બોર્ન થયો છું ત્યાં તક, કે એવરી ટાઈમ આઈ એમ ડુઈંગ, માય મધર ઇઝ કમિંગ એન્ડ ટેકિંગ મી એન્ડ ટેકિંગ કેર ઓફ મી. સો માય નીડ્સ આર ગેટિંગ ફુલફિલ્ડ ફ્રોમ માય મધર. પણ એટલે એને જાતે ને જાતે હેન્ડ ટુ માઉથ કરવાનું સ્ટાર્ટ કરી નાખ્યું. ઈ રડ્યું નહીં, ઈ લાંબો સમય માટે ખાલી રડતું હતું એવું નહોતું. ઈ પોતાની મેળે જ ફિઝિયોલોજિકલી ઓનલી લર્ન ધીસ પેટર્ન ઓફ ડુઈંગ હેન્ડ ટુ માઉથ. નાઉ ધીસ ઇઝ વેરી ઇમ્પોર્ટન્ટ કે every time the barak had the memory कि it is regulating itself, કેમ કે the mother was there every time to take care of the child. All right. So we have, as pediatricians, as nurses, we know that in the NICU, there is state regulation. Now, state regulation is extremely important. It's the optimal regulatory capacity, which is seen in a stable, alert infant that maintains the motor and the autonomic control. Now, why is it important? Regulation of state and maintenance of alertness in the early infancy helps the child to learn. એટલે પ્રીટર્મ બેબીઝને માટે શું થાય આમાં કે બીકોઝ ઓફ ધીસ પુઅર સ્ટેટ રેગ્યુલેશન એ લોકોનું મેચ્યોરેશન જ બ્રેનમાં નથી થતું. એટલે આ બાળકો જ્યારે આગળ જઈને લર્નિંગ ડિસેબિલિટી સાથે કે હાઇપર એક્ટિવિટી સાથે આવે છે ત્યારે પ્રોબ્લેમ સ્ટાર્ટ થયેલો because they were in the NICU and that time there was a huge period of time that they were away from the caregiver or the parent. So now let's understand कि इस state regulation માટે what are the normal state regulation of a newborn. એક નાનું બાળક, એક નવજાત શિશુનું state regulation normal કેવું રહે છે એ આપણે સમજશું ને તો આપણને ખબર છે કે abnormal શું છે. Okay, so now there are states of regulation, understanding the behavior of a term infant. Now we know that as the first state, there's a quiet sleep state. E quiet sleep state માં શું થાય છે? બાળક એટલું બધું શાંત છે, પોતાની માફક સૂતું છે. વી વોન્ટ બેબીઝ ટુ સ્લીપ ફોર a specific period of time. તો એ વજહથી શું થાય કે જે ઓક્સિજન, the oxygen which was being used in the other body activities, those oxygen is now being used for brain growth. એટલે લોકોનું cell mitosis. My voice is okay. The cell mitosis and the replication happens, because of which the growth hormone is being released. એટલે આ oxygenation ના વજહથી શું થાય છે કે these બાળક, that oxygen is used for brain growth because bodyની activities ઓછી છે, તો that same oxygen is now being used for brain growth. So we want babies to sleep for longer. That is why we say કે બાળકને વધારે સુવા દો, થોડું વધારે એને એવું atmosphere આપો કે the child is sleeping for a long period of time. Now there is active sleep. Active sleep એટલે શું? Now this sleep is also important. કેમ કે શું થાય એમાં કે એમાં પ્રોસેસિંગ થાય છે. જે પણ ઇન્ફોર્મેશન એને સેન્સરી એન્વાયરમેન્ટથી મળી રહી છે, the બાળક is processing in the brain, and this processing helps the બાળક to store the information. So this sleep is also important. One is a deep sleep state, the second is the active sleep state. Now the third state is the drowsiness state. એમાં કાં તો બાળક active sleep માં ચાલી જશે કે પછી બાળક પાછું quiet alert માં ચાલી જશે. બંને possible છે. It's in the drowsy state. Okay, so it's in between the active sleep and the active alert state. Now with the active alert state, what happens is that the infant are most attentive in this environment. Active alert માં શું કરે? He's paying attention. He's finally active. He's interacting with the parent. He's interacting. He's looking at the voice of the mother, looking at the face of the mother. It's moving objects, etc. So that becomes very important for the child to interact with the environment. This state is also important. So all that we are discussing is that active alert thi baby quiet alert thi the child is also coming in active alert state. Now the active alert state, the infant's eyes are open. એટલે હવે એક્ટિવિટી કરી રહ્યું છે, બોડીની એક્ટિવિટી એને વધારી નાખી. કોઈ આઈસ થી થોડુંક જેટલું એક્ટિવ અલર્ટમાં હતું એટલું ક્વાયટ અલર્ટમાં હતું એટલું એક્ટિવ અલર્ટમાં નથી, પણ એની એક્ટિવિટી ઓફ ધ બોડી ઇઝ ઇમ્પ્રુવિંગ. સો એ એક્ટિવિટી ઓફ ધ બોડી ઇઝ હેલ્પિંગ ધ ચાઇલ્ડ ટુ ડુ અ મોટર લર્નિંગ. ઓકે. Now is the crying state. Now crying state is showing what? That the child has a need. બાળકને કશું જુએ છે એટલે ક્રાઇંગ સ્ટેટમાં આવે છે. So as you can see now with the pictures were not, I think, getting downloaded in the earlier slide. So if you see that in the quiet sleep, the baby is very, very comfortable sleeping position ma, active sleep ma, also he is sleeping, but there is some, the mind is still active, so he's learning from the sensory environment. Drowsiness, it's either in the active sleep or in the active alert state. It either goes to one of it. In the active alert state, his eyes are open, but the activity of the body is more. Here the child is learning how to do motor development. And then is the crying state. Ema શું થાય છે? The child is constantly intensely crying. અને આ state જો વધી ગઈ બાળક માટે તો it is not able to again regulate itself. So આ બધા સ્ટેટ્સ હું શું કામ હમણાં ડિસ્કસ કરું છું? કેમ કે આ બાળક માટે, એક નોર્મલ ચાઇલ્ડ માટે, it is very easy for them to do the transition. કે એક્ટિવ સ્લીપમાં હતું એમાંથી એક્ટિવ ક્વાયટ સ્લીપમાં ચાલી ગયું કે ડ્રાઉસીનેસમાં ચાલ્યું. તો આ જે ટ્રાન્ઝિશન થાય છે ને, it's very smooth in normal children. But for our babies who are at high risk, this becomes a problem for them when they cannot do the transition very smoothly. Either they stay in a lot of time where they are only crying, or they stay in a lot of time where they are constantly sleeping. તો બધાના જ એડવાન્ટેજીસ ડિસએડવાન્ટેજીસ છે. જો એ લોકો બહુ સમય સુધી એ સ્ટેટમાં રહ્યા અને એનું પ્રમાણ એનું ચાલી ગયું તો પછી એ મૂવમેન્ટ કરતું કે એ સેન્સરી પ્રોસેસિંગ કરતું થોડું એ લોકો માટે ડિફિકલ્ટ પડી જશે. So normal infants regulate કરતા તો પછી ક્યાંથી શીખે છે? એ રેગ્યુલેટ કરતા આ બધું આપણે જ્યારે વાત કરી, આ વિડીયો પણ જોયો, તો એ રેગ્યુલેટ કરતા ક્યાંથી શીખે? પોતાના એક્ટિવિટીઝથી શીખે છે, કે હેન્ડ ટુ માઉથ જાય, ફિસ્ટિંગ કરે, ઇવન બ્રેથ. એ લોકો જો ડીપ રેસ્પિરેશન પણ કરી શકે ને જાતે, તો ધેટ ઓલ્સો હેલ્પ્સ ધેમ ઇન રેગ્યુલેટિંગ. તો હવે when they come to the NICU, we know that they have some respiratory problems. They might have some times that they also go on ventilators. So as physiotherapists, we know, as nurses, we know that we want them to get weaned off faster. We want them to improve. So we give them chest physiotherapy. We do a lot of things where their breathing improves. So a breath also plays a role in regulating the child. It also regulates differently, like, giving a sign of yawning, giving a sign of sneezing. So all of this is the normal regulation that the child learns slowly. Next slide. So what are the factors influencing the infant state? Now, these factors become extremely important. Because our other factors are the stress. Sometimes there are stressful situations. There are various drugs that they are on. There are medications on. There are some internal physiological needs that they come up with. So just to discuss a few, if there's a stressful event, say suppose there's a painful event for them, તો જ્યારે એ બાળક actually NICUમાં હતું, એ કોઈક વાર જો normal હોત તો એ sleeping stateમાં હોત positionમાં. But now repeatedly they are going to get these IV lines, which are of course necessary for them. They're going to go on an incubator, or they have some painful experience. So each sleep state is getting deprived. There's a deprivation period for them, and because of that, they either stay in a fussiness state, or they are always not able to sleep. So we know in the NICU when we go, when we see regularly those kids, we see that they, some babies are always crying. Like when we go, sometimes the nurses will tell us कि आप बालक सूतु ज નથી. So we know कि we need to intervene those babies who are not sleeping. So that's where we know कि which environment is going to help them to go back to the quiet sleep state. Okay, so like that, we also have the internal physiological needs. They have hunger, or they've got satisfied with their food. So all these factors are influencing the infant state. There are pathological conditions also because of which they are in the NICU. They have either jaundice or they have microcephaly. They are in coma. They have some kind of intrauterine growth retardation. આ બધાના લીધે hypoglycemia etc. So આ બધાના લીધે શું થશે કે એ લોકો પાછું સ્લીપ સાયકલ્સ એ લોકોની ડિસ્ટર્બ થતી રહેશે. એટલે આપણી રિસ્પોન્સિબિલિટી ત્યારે શું થઈ જાય કે આ લોકોને વધારે ને વધારે સમય એવો આપવાનો કે એ લોકો બેલેન્સ રીતે આ બધા ટ્રાન્ઝિશન સ્ટેટ્સના કરી શકે છે. એ લોકો ક્વાઇટ સ્લીપ સ્ટેટમાં આરામથી જઈ શકે છે. એ લોકો બહુ ક્રાઇંગ સ્ટેટમાં નથી રહેતા. એ લોકો એક્ટિવ સ્ટેટમાં પણ રહે છે where they are interacting with the environment. So as therapists, as nurses, we have to interact back to them. Okay. Now is the self-regulation in the early infancy. So where does self-regulation come from early infancy? They learned the patterns from their mothers. Now babies are quickly conditioned to associated mothers hold with feeding and then immediately rooting. Learns to respond to the mother's voice, touch, smell within a few days. Easily associates crying behavior with being picked up, and learns to modulate parents' behavior by their own behavior. The child is learning everything from the caregiver. So it slowly learns the patterns of the caregiver. Okay, the caregiver is taking care of it, then it's also responding to it. So all these patterns are learned when they come outside and they start learning those behaviors. So coping strategies, that is why, coping mechanisms have to be taught to them. When they cannot learn this, it is very important for us as therapists to teach them these behaviors. So factors, in environmental factors je state modulation ma affect karta tha, so we know that there were internal factors like temperature, immaturity, pain, stress, even the maternal substance abuse, which is becoming now a very big thing for parents. Like if you see a lot of babies with fetal alcohol syndrome, all these illnesses, then there is an environmental factor. બહારથી અવાજનું ફેક્ટર છે, વાઇબ્રેશન છે, લાઇટ છે, ટેમ્પરેચર છે. તો આ બધી જ ચીજને આપણે મોડ્યુલેટ કરી શકીએ છીએ. So the question here is in the NICU, how do we change the environmental factors and how we can also change the internal factors? So these coping behaviors again become important. So now to understand what are the coping behaviors, I'll first tell you all about the list of behaviors where they can do a self-regulation. And there are a list of behaviors where we can pick up that the self-regulation is not happening, and that is why the baby is showing a stress. So what are the self-regulation behaviors that the baby shows? It either munches, it smiles, protrudes the trunk, raises the eyebrows, it has a hand to face or hand to mouth, it does a clasp, okay, or it does a foot brace. So all these mechanisms are a very good mechanism. They are good, like they're helping the child to regulate itself. But આ બીજા જે તમે જોઈ શકો છો જે stress behaviors છે એ કયા છે? So child has started yawning, or it started kicking a lot, or it's doing a salute, or it's startled. So a બધા behaviors is showing that the child is in stress. So again, as therapists, as nurses, we need to know, even as doctors, we need to know that these stress behaviors show that the baby is trying to communicate that it's in pain, or it has some discomfort which is taking place. Now, again, very important when we look at the child as a whole, we are trying to give the child as much as holistic approach possible, from the early age. Now, every time that we discuss about the physical development or max to max sensory development, સ્પીચ ડેવલપમેન્ટ, બાળક બોલે છે કે નહીં, બાળક ચાલે છે કે નહીં, બાળક બરાબર કોગ્નિટિવલી થાય છે કે નહીં. પણ every time we don't really pay attention to its social development, its emotional development, or we don't have it as a checklist કે આ checklist મારે જોવાનું જ છે કે આ child emotionally develop થઈ રહ્યું છે કે નહીં. So it's very important કે if there is a missing link there કે the child has missed one step of self-regulation, then this critical cognitive self-regulation steps will be missed later. So shortly, just to show what the early development of regulation looks like, we'll see what are the development of cognition and what is the development of social and emotional of a normal child. So from 0 to 12 months of age, as development, the cognition of the child develops with what all? The child learns how to grasp, to reach, to manipulate the object. It begins to participate and predict a sequence. એને ખબર છે કે આના પછી આ થશે. એટલું નાનું prediction, it starts in the first year only of life. Then from 12 to 36 months of age, it does a goal-oriented behavior. એટલે શું કે ચાઇલ્ડે સપોઝ કોઈ જોતું છે, એને કોઈ ટોય જોવે છે કે એની પાસે એને કોઈ પાણી જોવે છે કે કશું પણ જોવે છે, તો એ પોતાની મેળે પ્લાન કરશે, એ ત્યાં જશે અને એ ટોયને હાથમાં લેશે. So that is called a goal-directed behavior. Now from 3 to 6 years of age, the child is learning. Now it's almost at 6 years of life. So it knows કે આ મને help કરશે, મારે હવે આ ચીજ ઉપર attention આપવાનું છે. So if I'm talking to you all right now, so I have to pay attention right now here. I don't have to see whether the slides are playing well or not. I know there are people helping me. So one place I have to pay attention, and the other distractions which are there, that I have to resist it. So to control attention and to resist distraction is very important, and this comes from a very early age, not right now. Right now it's been matured. એટલે આ મેચ્યોરિટી 6 years પર તો આવી જ જવી જોઈએ. જો નથી આવી, that means the problem happened much earlier where the child didn't regulate itself. So when we have kids coming to us at say 4 years of age or 6 years of age, when they go to school, the parents complain or the teachers complain, the child is not paying attention, આખો વખત બારીની બહાર જ જોયા રાખે છે. So we know there was a link which was missing, જે early age માં, જે NICU માં કે early infancy માં we could have taken care of. So I will tell that how we can pick up those later, and at what age can we actually pick them up. So not that, maybe not at 0 age really that we will be able to pick up all the signs, but ધીમે ધીમે we know that the child has got into this maturity. જો એને grasping ત્યારે ઓલું નહીં કર્યું કે એક behavioral sequence નહીં આપ્યું at 0 to 12, તો આ missing link હોઈ શકે એ લોકો માટે. All right, and now we have the social and the emotional development as well. That means what? From 0 to 12 months of age, the child knows how to do the sleep wake up cycle. Now hamara profile ma what we check is we really check the sleep and wake up cycles. We want to know for how many hours the child is sleeping and for how many hours is the child in the waking state. This gives a lot of information. So if we see about our evaluations, this becomes a very, very important factor for us to understand that what the child is going through. So sometimes the mothers come to us and they say that the baby just doesn't sleep even after discharge. The baby has gone home, early intervention clinic ma આવ્યું at 6 months or something, so કે આખો વખત કાં તો રડ્યા રાખે છે. The mother is in stress because રાતના પણ સૂતું નથી અને સવારના પણ સૂતું નથી. So the mother has to always keep attending the child. So we have interventions where we take care of their sleep. કે એવા જ interventions program આપે કે skills આપે mothers ને શીખડાવે કે કેવી રીતે બાળકને સુવડાવવાનું. All right. Then from 12 to 36 months of age, what happens is these children understand empathy. Very important. Now empathy means what? હવે હું પેનમાં છું. ઓકે, હું પેનમાં છું તો બાળકને ખબર પડે છે કે મને પેન થાય છે. એટલું જ નહીં, બાળકને પણ પેન થાય છે કેમ કે કોઈ બીજું પેનમાં છે. Very important. I think this is the most important when we look at emotional intelligence of the child. So this awareness of others or and the feeling of others is being understood by the child at 36 months. From 12 to 36 months, this has been matured in them. Then from 3 to 6 years of age, what is the emotional development for them? So it has been able to more capable of controlling emotions. એન્ડ ઇટ નોઝ કે મારા રૂલ્સ કયા છે અને મારે કઈ ચીજમાંથી રિફ્રેન કરવાનું છે, કે મને આ ચીજ ફોલો કરવાની છે. મમ્મીએ કીધું છે કે મને આ ટાઈમ ટેબલ ફોલો કરવાનું છે, તો એ રીતે જ જશે. અને આ નથી કરવાનું તો એ કોઈ વાર કરે, પણ એવું નથી, પણ એ નોઝ કે this I don't have to do. એ રીતે begins to talk about mental states of self and others. પોતાનું મેન્ટલ સ્ટેટ કેવું છે એ તો જણાવે જ, અને બીજાનું મેન્ટલ સ્ટેટ. હવે આજે મમ્મી બહુ ગુસ્સામાં છે તો એને ખબર પડી જાય છે કે આજે મમ્મી ગુસ્સામાં છે તો આજે તો મારું બની જવાનું છે, એટલે આઈ માઇટ એઝ વેલ સ્ટે ઇન હું ડાયો રહું અને I'll take care of her also. So this becomes important for them કેમ કે એ 3 to 6 years of એજમાં આવી જાય. Alright, next. So this critical period becomes important, and as a team, like we all have to take care of this at the critical hour. When we know that the child has come to us in the NICU, a critical time we can intervene them, we can take care of them, we can do small things like very very basic things which can help them improve their emotional life, their social life, and later on even their mental status will be taken care of. So now let's understand self-regulation, where it develops. So it develops from attachment. Attachment એટલે શું? એ લોકોને એક secured attachment જો એ લોકોના caregivers પાસેથી મળ્યું હશે કે mothers પાસેથી મળ્યું હશે, then this can be easily taken care of. Now we right now understand that first time that the baby meets the mother, what happens? So when the first time, okay, when the baby is out of the womb and the first meet of the mother and the child, that meet is the first date of the mother to the child. એમાં શું થાય છે કે એમાં the child is seeing himself in the eyes of the mother. એ પહેલા તો he doesn't know કે he is existing, તો એ existence એ એના મમ્મીના આંખમાં જોવે છે. So what happens in that મધરનું પણ emotional bulb, that is it can be compared like a Christmas tree light bulb. તો એ light bulb મધરનું પણ activate થાય અને childનું પણ activate થાય છે. તો એ ક્યાં activate થાય છે? Activating in the right frontal lobe. So and that is why the right hemisphere in the brain becomes important, because it is important for non-verbal spatial processing, in the sing-song voice, the face recognition, and seeing the big picture. Our development કેટલા વખત સુધી થાય છે? From the first 18 to 30 months of age, એ right hemisphere જ વધારે use કરે છે બાળક. પછી ધીમે ધીમે શું થાય કે લેફ્ટ હેમિસ્ફિયર જેવી રીતે લોજિક, રીઝનિંગ, એવરીથિંગ સ્ટાર્ટ્સ, then this left hemisphere is it's dominating the right hemisphere, and that is why the child learns a lot of logical thinking in the after say 2 years or 2.5 years of life. So the right hemisphere in the first 2 years of life is the CEO, that is the boss of self-regulation. એ જો very well maintained રહ્યું ને તો આગળ જઈને એને લિમ્બિક બ્રેન છે, જે ઇમોશનલ પાર્ટ ઓફ ધ કોર્ટેક્સ છે, એ એને કામ કરતા આવડી જશે. So the right orbital frontal cortex, the activation એને ક્યારે થયું? The first meet with the mother જ્યારે થયું ત્યારે એને એક્ટિવેટ કરવાનું સ્ટાર્ટ કરી નાખ્યું. એ ધીમે ધીમે ડેવલપ થતું ગયું, બહુ બ્યુટિફુલી ડેવલપ થયું. તો શું થયું? That child will be able to regulate himself. Regulation એટલે શું? એ કાં તો બહુ હાઈ ઓલા પર નહીં ચાલ્યો જાય કે હવે suppose I'll just give you an example. Say a boss shouted at you. So if the boss shouts at you, you do not shout back at the boss. You'll be fired. તમને કહેશે કે you just leave the job. So તમે લોકો આપણે શું કરીએ ત્યારે કે we just regulate. We cannot shout back. So we regulate and come to that arousal state where we can manage ourselves. So that starts happening in the child as well. ધીમે ધીમે once the self-regulatory mechanism starts coming in the child. So the right orbital frontal cortex is also important for their heart rate, for their hormones, and for control of the autonomic nervous system. This tells the amygdala. Amygdala is a part of the brain in the cortex to calm down any kind of mechanism જે એને dysregulate કરી રહ્યું છે. Calm down mechanism એ શીખવાનું start કરી રાખે છે amygdala. So amygdala is simply nothing but a part of the brain which takes care of this fright mechanism. હવે કોઈ પણ danger આવે છે કે કશું પણ થાય છે, so it knows how to calm itself. So So regulation through sensitive caregivers. Now that is why, as now we know that sometimes the mother getting into the NIC also becomes a problem many of the times. So શું થાય કે mothers are not coming inside all the time. So as nurses, as therapists, when we go to the child, we can talk to them, we can just play with them for some time, or just give them some kind of touch, some kind of this thing where they feel that they've been cared for. So this soothing behaviors do what? The child learns how to transform a state of stress into calmness. કે એને ખબર છે there's somebody to take care of me, so I will calm down. This state of calm is mediated by the activation of the parasympathetic nervous system, which lowers the heart rate and also activates the brain circuit that help the child learn to self-regulate. So as we saw that the first time the child met the mother, એને શું કર્યું? એને આંખથી જાણ્યું કે વર્લ્ડને કેવી રીતે પરસીવ કરે છે, કોણ છે, શું છે. So reading the mind and the eyes. Why are we discussing this? Because sometimes what happens is, as therapists, I have so many things. I have to take care of this child. અચ્છા, એના પછી 4 પેશન્ટ છે. ઓલરેડી એક પેશન્ટ મારું early intervention center માં વેઇટ કરી રહ્યું છે. ફટાફટ I have to finish NICU work and go there. So I'm in stress. I'm thinking of 10,000 things when I'm treating the child. I'm giving positioning, fatafat, making sure that he's fine, and then leaving. But the child perceived me. The child knew very well that this therapist was in some kind of stress, and that perception made him understand that, oh, there's nobody to take care of me right now. So the child understands through eyes. So right now I'm just telling you a very small, very interesting thing, which all expressions the child picks up. So these micro expressions in them are slowly picked up. Okay, I'm in sadness, suppose, or I'm in anger, or say I'm in disgust, I'm in fear. So all of this the child is picking up. Or today I'm in a very good state. I'm very, very happy. I had very good day today. I'm really this thing. Child picks up that as well. So it's very important, very, very important. You're looking at a very sensitive thing here. કે આપણું પોતાનું પણ mindset is going to affect the child. So this becomes important for us to understand that we cannot, as people in the NICU, working just mechanically. We have to be really, really, connecting to the child, be mindful about our thoughts as well, keep them aside for a while. You can, deal with it later, but also connect to the child. So secure attachment becomes important. Now this secure attachment, we as caregivers in the NICU need to take care of. Child displaces feelings of discomfort. So child displaces feeling of discomfort due to any external stress, and the caregiver provides physical, mental band-aid response. Okay, we are the bandages to the child, to allow the child to down regulate. As we talk about the boss, we spoke about the down regulation. We don't want to be as high as what they are. So we have to down regulate and organize themselves. So this becomes important when we look at the child. And physical and mental bandages kon che? Apne loko che. As professionals in the NICU, we really need to be careful about this. And what is the insecure attachment? So if you see in this picture, you see this baby just lying down on the floor. Okay, and what do you see? The mother is constantly on the phone. Imagine, like, the child is just left like that. So what is the child going to perceive? It's only giving the feeling that, there are suppressed emotions in it. Okay, there's nobody to take care of me. So this occurs when the caregiver is constantly unavailable to organize or aid towards the child's feeling of discomfort. The child learns to inhibit their feelings, suppress it, or shout it off. The child is inhibiting the feeling, it's suppressing the feeling, or it's shutting it off. And examples of this can be, the child has stopped crying only. It's just given up. No crying, nothing. Okay? It stiffens the body. Gaze कोई का ऊपर कहीं नाखे, आँख ऊपर कहीं नाखे. अथवा तो कोई danger आवे, तो एकदम blank face, as if there's nothing happening. Danger छे, but there's nothing happening because he doesn't know where to go. These children are also overthinkers in future. So they think a lot. They think a lot. 4 step already સોચી લીધા છે કે હમણાં આ problem આવે છે તો એના પછી હું શું કરીશું. They are overthinkers. Such behaviors emerge as young as 8 months. So we can catch it as early as 8 months. આ બધું આપણે ક્યારથી catch કરી શકશું? 8 months. And now we know that the development of emotions and the development of cognition ક્યાંથી આવે છે. So when this behavior processes with age, they are more likely to commit suicide. Now, isn't that shocking? That's really, really shocking. And we know that mental health now is becoming a difficult task for everybody. It's not, aa badi cheez to we can take care of. So we have to not reach that state only where the child can have this kind of emotional setup later. So emotional health of the parent on the child's brain. What happens now? The dopamine chemical is being produced. It's an important chemical essential for motivation and attention. So a chemical jo attention and motivation બાળકને નથી મળ્યું તો એ ડોપામિન લેવલ્સમાં લો થઈ રહ્યું છે. એ શું થશે? એ ડોપામિન લેવલ્સ ડિમિનિશ થશે ને મધરમાં, તો એ ચાઇલ્ડમાં પણ ડિમિનિશ થશે. હવે શું થયું કે મધરનું તો ડોપામિન લેવલ નોર્મલ થઈ ગયું, પણ ચાઇલ્ડનું ડિમિનિશ જ રહ્યું. કેટલું ઇમ્પોર્ટન્ટ છે કે મધર સપોઝ postpartum depression માં હતી, and her dopamine levels were low. એમાં પાછું સેપરેશન કોઈક વાર આવી ગયું મધરને કે mother and child are separate right now because of the NICU, long stay in the NICU or long illness or any kind of other problem. Then what happened is her dopamine level affected the child's dopamine level also to decrease. But she came out of it. The child came out of the NICU. He was fine. He was with the mother. Dopamine levels of the mother increased, but child's dopamine levels yet remain the same. So it remits. It stays in that position for a long time. Next. So infants do not understand words. That is why I've talked about so much micro expression thi laine, eyes thi laine, face thi laine. They understand through expression. Their whole brain architecture is right now built with the right hemisphere of the brain, which is responsible for emotions. So બાળક શું સમજે છે? બાળક emotion સમજે છે. બાળક language of emotion, body language સમજે છે. એ વજહથી શું થાય છે કે when mother is expressing emotion of say fear, the child is reflecting this feeling as they believe that fear આવ્યું તો એ લોકોને લાગ્યું કે આ mother she only cannot take care of it, so how she'll take care of me? So they don't have the feeling of protection at all. The mother's pupil, voice, confidence, એ બધું પણ affect કરે છે. So if the mother is in a relaxed state, or if the mother is constantly allowed in the NICU to come and interact with the child, so she will also remain in a relaxed state. So આપણે ખાલી બાળકનું નથી સોચવાનું, આપણે મધરનું, આપણે એના ફેમિલીનું પણ સોચવાનું છે કે how the mother's mental status, કેમકે એની જો mental state સારી રહેશે તો ચાઇલ્ડની પણ mental state સારી રહેશે. Yeah. So now a very, very beautiful experiment that took place. I mean, we are just going to show that. It's a very beautiful experiment. I would like you all to see it, and no worries if you all can't see it. Then we can definitely discuss it later. And a બહુ મસ્ત experiment છે. Just briefly explain you about the experiment. એક બાળક છે, એક માતા છે. માતા બાળક સાથે વાત કરી રહી છે, તો બાળક શું કરે છે? બાળક પણ માતા સાથે રિસ્પોન્ડ કરે છે. પછી એક એક્સપેરિમેન્ટ એવી રીતે કરવામાં આવે છે જ્યાં મધર્સ ફેસ ઇઝ કમ્પ્લીટલી સ્ટીલ. શી ઇઝ નોટ શોઈંગ એની ઇમોશન, નથિંગ. શી ઇઝ જસ્ટ સ્ટીલ. તો એ વખતે બાળક શું કરે છે? It's very important to see what the child is doing. Let's quickly go through the video, and then you all can note down your observations. Later પછી આપણું એક વખત આ presentation પતી જાય કેવી રીતે, then we can also discuss if there is anything. You all can put it on the chat box.
Parents who are stressed have been shown not to be able to be as attuned to their infants and children as parents who are not stressed. Not their fault, not because they don't love the child. not because they're not dedicated, devoted, committed, simply because stress effect impedes their ability not to love their child, but to attune with their child. So that mutual responsiveness is interfered with. And that has an impact on brain development. There's an important chemical called dopamine. Dopamine is essential for motivation and attention. Now you take infant monkeys and you measure their dopamine levels in the front part of the brain, and you find it to be normal. Separate them from their mothers, those dopamine levels have diminished. In other words, the child's brain chemistry is affected by the unavailability of the mother. And this is true even if the mother is physically there, but emotionally absent.
Imagine two tuning forks, like in this very famous still face experiment. The mother is one tuning fork, and it starts vibrating. And the baby's tuning fork begins to vibrate in unison with hers. And when that happens, gradually its own prefrontal cortex gets tuned. So it becomes empathic. It begins to relate to the mother.
Infants don't understand words, so they respond to body language. So is my mother rigid or relaxed? Is she afraid? Because if she's afraid, I am, because she's my protector. If she's afraid, who's going to protect me? The size of the mother's pupils, the mother's voice. Is it confident and relaxed, or is it tense? Those aren't conscious thoughts, but this is the infant's experience.
Depressed mothers, or even worse, schizophrenic mothers, they are not in synchrony. The baby is getting the message that there's something wrong with it. Its prefrontal cortex is not going to be tuned properly. So that baby is going to develop a kind of depressive personality.
I'm here. And what are you doing? Oh, yes. Oh. The monkeys tell us more about the severe effects of infant deprivation. The ones that were reared in isolation just don't behave normally when they're finally given a playmate. They rarely touch, and when they do, the contact's surprisingly vicious.
Children who are emotionally inhibited will become dysfunctional adults. They will have difficulty learning and will be more hostile. And that starts right in the womb.
All right. Okay, sorry about that again. So, as we saw now, this is a very beautiful experiment. અને એમાં આપણે જે રીતે જોયું કે મધરનું interaction with the child છે, and the child is interacting back when the mother is interacting with the child. But when mother is going in a still face, where she's not showing any emotions, that time the child it doesn't know what to do. It feels so insecure કે હવે મારું એટલે who's going to protect me, અને એમાં જો stressful event આવી so it doesn't know how to cope up only. So again, this is getting more and more important because the mother's mental health, everything plays an important role. Okay, so now just quickly going through. So body language tells a lot, as we know. So what do you feel that this body language tells you? This body language is simply saying that the child, that the dog is in this position. So it's just showing a lot of empathy. If you see this faces, it's showing that it's giving you a lot of empathy, a lot of compassion. That is why it's going onto the side of the head and looking at you. So similarly, similarly, when you see these micro expressions of compassion, does what? It helps to regulate others. Koi pan hoye, and it's not only about children, it's also about somebody who is in stress. Ene pan apne empathy dekhadvi hoy, compassion dekhadva hoy, so you soften your eyes, you lean onto your right, and then genuinely care for that person. So this becomes important when you go next to the baby, when you know that you're going and intervening for a very stressful event. Kai tamare IVs appa na jave, ke there is a long stay in the ventilator, or the child is in too much pain. So pain has been experienced by them. So એ વજહથી શું થાય છે કે they are, when you go to them, be in that expression. Now, eye contact. Now, what is happening here is that the child, okay, so many kids come to us with sensory processing disorders later, કે એને eye contact જ આપતો નથી બાળક, કે he's not looking at us back, આંખમાં આંખ મલાવતો નથી. અને એ વચ્ચેથી these are very, very common symptoms of an autism child, where autistic kids want to stay in their own cocoon, they do not interact with the caregiver or with the environment. So this might be a little difficult for them to do. Why? Because that they lacked in the early age. Similarly, tone of the voice. Now you know that you're going and doing a, so when we are under stress, our tone of voice changes, taking on a quality of irritability and frustration. This will immediately stimulate a defense reaction in the listener's brain even before the conversation starts. We say that when in the NICU, when a lot of interaction is happening in front of the bed of the NICU, we really request our doctors and nurses not to do that interaction at least next to the bed. They can go a little away and then discuss the child or do whatever is needed, because that also is creating a lot of stress in the child. Now, being present is very important. So if you see, that the mother's presence, the mother's mindfulness when she's interacting with a child, or as caretakers for us also as professionals when we go in the NICU, being present and mindful is important. We spoke about it earlier, so I'll go quickly fast. So rhythm provides structure for movement, telling us how to move through time and space. Rhythm એટલે શું? તમે બાળક સાથે પ્રેમથી વાત કરો, એ repetitive rhythmic way માં વાત કરો, આ લા 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 કરો, એ લોકોની સાથે ચાલો, એ લોકોની સાથે you sit with them, you sing a song to them, you dance with them. So what happens in them, that uses the brainstem, and that creates a somatosensory network in the child. So this again becomes important for them, for their limbic system and for their cortical thinking. And that is why we spoke about the role of the amygdala. It rapidly perceives a sensory stimuli as either positive or negative. When it detects something interesting, it signals. There's something interesting happening. What the brain perceives? The brain perceives it as interesting. This signals the hippocampus to start laying down good memories. In hippocampus is again responsible part of the brain which sets up the memories. In nervy learning માટે ખૂબ important થઈ જાય છે later on. When it detects danger, it activates the fight-flight mechanism and it prevents learning. જ્યારે danger આવે કે જ્યારે કોઈ problem આવે છે ત્યારે flight mechanism high થઈ જાય છે, જે શું કરે છે? Again, it's not helping the child to do a new learning. So amygdala is mature a month before birth, while the higher brain order that regulates the amygdala takes years to mature. It is so કે amygdala maturation 1 month before birth already થઈ ગઈ છે. So એ હવે જ્યારે બહાર નીકળું ત્યારે it started laying down memories, either good or bad. પણ જો good memories એની વધી તો એને that will become responsible for its self regulatory development, કે એ આગળ જઈને self regulation ખૂબ સારી રીતે development કરી શકશે એ ચીજનું. So amygdala maturation again આપણા માટે helpful બહુ important એટલે થઈ જાય છે, કેમ કે પ્રીમેચ્યોરિટીમાં એ કોઈકવાર મેચ્યોર આપણી સાથે થાય છે ઇન ધ ફર્સ્ટ month when the child is in the NICU. So એને સારા એક્સપિરિયન્સીસ આપવા, એને એ કન્ટેન્ટમેન્ટ હોલ્ડ આપવું, એને પોઝિશનર્સ આપવા, એને એવી હૂફ આપવી એ ખૂબ મહત્વનું થઈ જાય છે. And just to sum up that the brain, so neglect vakte what is happening, just what we all saw, okay, there is separation, there can be a long stay in the NICU, the child is in painful situations, in painful procedures are taking place on the child, self-regulatory mechanisms are missing. So we know that there's some kind of neglect to the brain as well, because the mother all the time is not available for the child. We have to be available for the child for most of the times, or make the environment like that so that they do not feel that they are away from the mother's womb. So badhu will make their brains more and more developed, not only emotionally, not only intellectually, but also later on for their mental growth, for their mental health. It becomes very, very important. So I would now just like so just to end, that prevention is in our hands, and let's not reach the state where the child is not with us with a mental state of mind. So let's also look at their emotional emotional quotient, and also look at their social and emotional interactions. So now I will just ask Dr. Neha to. Sorry, there's one more video that we just will like to show. Y'all can see this, and then we'll end this talk. All right, so this is one of the example of a self-regulation, how a self-regulating mechanism is being taught to the child by doing a simple hand to mouth. ખાલી એક જ video દેખાડ્યો તમને કે hand to mouth કેવી રીતે કરીને at least the little that the child can regulate itself. એટલે ઈ પોતે કોઈકવાર hand to mouth ન કરી શકે because of the lack of movement that it has. The therapist teaches the child to do a hand to mouth mechanism. આ આગળ જઈને શું કરશે, soothes the baby's neurological system, and that helps the baby to grow better. So we have few more talks, so I will just ask Dr. Neha to continue. So she'll be talking about neuroplasticity and what happens again in the brain where neuroplasticity occurs, and that again becomes helpful for the child to so neuroplasticity is very, very important in the first few years of life, and she'll talk about it and tell us the importance of it.
Thank you, Dr. Payal. So I think this session was good enough to show us about the self-regulation. And if questions, so I think at the end of the thing, after we present up all the 4 presentations, you can just put your questions in the chat box to address them. So going on to the next presentation, which is on neuroplasticity, Dr. Neha, she's a qualified occupational therapist, and she has worked in London in various rehab units, and she has a special interest and focus on neuro rehabilitation for the last 12 years. And she has been actively involved with the Shrimad Rajchandra mission, and she's also actively working in the Shrimad Rajchandra DEIC. So I would like to ask Dr. Neha to take over from here and tell us more about neuroplasticity. Over to you, Dr. Neha.
Thank you, Dr. Gauraj. A very good afternoon to everyone. Give me 1 second and I'll start with you all. Okay. Excellent. So now we can see the slides. I'll talk about the neural plasticity. I'm sure the topic is not very new, but some information will share which will help you to understand and to how to and when to intervene quickly in order to prevent, as Dr. Payal suggested. So that will be our aim for this talk today. So neuroplasticity, what is neuroplasticity? As we all know, neuroplasticity is the organization of the neurons in response to the new experiences. So neural plasticity specifically refers to uh, strengthening or weakening nerve connections or adding new nerve cells based on outside experiences. So the neuroplasticity basically work in a many different fashions as well in the brain when the brain is developing. But the two mechanisms which is very basic in which it forms its place is they are called axonal sprouting and synaptic pruning. And let's see that how and what way they work. So axonal sprouting, in this one, if you can see the diagram, in axonal sprouting, healthy axons sprout new nerve endings that connect to the other pathways in the nervous system. And this can be used to strengthen existing connections or to repair damaged parts of the nervous system by repairing the damaged neural pathways and restoring them in the full functionality. So if you can see the top one, there the sprouting is happening. And then in the second diagram at the bottom, you can see that with the experiences and lots of repetitions giving functionally or movements or things like that, those nerve again sprouts and develop the synaptic connections. Second is called synaptic pruning. Following the birth, the brain of the newborn is flooded in information from the baby's sense organs. So this sensory information must somehow make it back to the brain where it can be processed. Now to do so, the nerve cells must make connections with one another and transmitting the impulses to the brain. Now this synaptic pruning eliminates the weaker synaptic contacts while stronger connections are kept and strengthened. So with this pruning, what happens? The weak connections, they actually eliminate them, and whatever movements or whatever connections you want to strengthen and you give lot of repetitions of those, it will strengthen it up. Now experience determines which connections will be strengthened and which will be pruned. So connections that have been activated most frequently are preserved. It is the plasticity that enables the process of developing and pruning connections, allowing the brain to adapt itself to its new environment. So because we have this pruning facility in the brain and us as a functionally, we can adapt to many things and many situations as well. Certain facts about the synapses, about the neurons. So at birth, each neuron in the cerebral cortex has approximately 2,500 synapses. By the time, according to Gopnik et al. In 1999, the study says, by the time an infant is 2 or 3 year old, the number of synapses is approximately 15,000 synapses per neuron. This amount is about twice that of the average adult brain. As we age, old connections are deleted through a process called synaptic pruning, what we learned before. So આ જે સાયનાપ્સિસ છે આપણા બ્રેનમાં જે બર્થ ટાઈમે જેટલા હોય છે 2500 એ જ એટલા છે ને જેમ આપણે 2 થી 3 વર્ષના થઈએ તો 15000 પર ન્યુરોન થઈ જાય, એટલે કે ડબલ ધ સાઇઝ ઓફ એન એવરેજ એડલ્ટ બ્રેન. સો ઈ તમને કેવી રીતે હેલ્પ કરશે ઈ આપણે આગળ જોઈએ. Now we'll see કે why was the brain wired like that. આપણને એમ થાય કે બ્રેનમાં કેમ વાયરિંગ આવી રીતે થયું હશે, બટ બીકોઝ બ્રેનનું વાયરિંગ આટલું સરસ રીતે થયું છે એટલે આપણે કોઈ પણ ચીજને અડેપ્ટ ફાસ્ટ કરી શકીએ છીએ. So neuroplasticity is the natural tendency of the brain architect to shift in positive, એટલે કે adaptive responses or a negative, which is the maladaptive directions. એટલે એ આપણને બે રીતે એક તો હેલ્પફુલ બી થઈ શકે બીકોઝ ઓફ ધ વાયરિંગ એવી રીતે છે એટલે, અને કાં તો હાર્મફુલ પણ થઈ શકે જો આપણે એને maladaptive રીતે યુઝ કરશું તો. So the child brain is most malleable and undergo neurogenesis during 0 to 3 years. એટલે આપણી પાસે જે 0 to 3 વર્ષનો જે ટાઈમ પીરિયડ છે ને એ બહુ ઇમ્પોર્ટન્ટ છે. તેમાં આપણે કેવા કનેક્શન્સ સ્ટ્રેન્થન કરવા છે અને કેવા કનેક્શન્સ આપણે વીક કરવા છે. બીકોઝ જે ચીજ આપણને સ્ટ્રેન્થન કરવી છે ને એ ચીજ રેપિટેડલી કરાવશું તો ન્યુરોપ્લાસ્ટિસિટીનો મિકેનિઝમ આપણને એમ કહે છે કે એ કરવાથી એ કનેક્શન્સ, એ બિહેવિયર્સ, એ મૂવમેન્ટ પેટર્ન સ્ટ્રોંગ થશે, અને જે આપણને વીક કરવા છે એ પણ પોસિબિલિટી રહેશે. થોડાક એક્ઝામ્પલ જોઈ લઈએ. અડેપ્ટિવ પ્લાસ્ટિસિટી એટલે શું? જેમ કે ફંક્શનલ અને સ્ટ્રક્ચરલ ચેન્જીસ ઇન ધ બ્રેન એ આપણને કેવી રીતે એડવાન્ટેજીસ થશે. સો દેર આર ફ્યુ કન્ડિશન્સ જે રીતે આપણે દર્શાવી છે કે ફોર એક્ઝામ્પલ સ્ટ્રોક, ટ્રોમા, સ્પાઇનલ કોર્ડ ઇન્જરી, સેરિબ્રલ પોલ્સી, કે વિઝન પ્રોબ્લેમ, હિયરિંગ પ્રોબ્લેમ, એપિલેપ્સી આફ્ટર સર્જરી ઓર એની લર્નિંગ ડિફિકલ્ટીઝ કે કોઈ ક્રોનિક પેન, આવી કોઈ સિચ્યુએશન હોય ને તો એમાં આપણા બ્રેન પાસે કપેસિટી છે કે એ ફંક્શનલી અડેપ્ટ થઈ જશે. ફોર એક્ઝામ્પલ સ્ટ્રોક પછી જો કોઈનો રાઈટ સાઈડ ખોટો પડી ગયો હોય અને રાઈટ સાઈડથી તે કામ ન કરી શકતા હોય તો જો લેફ્ટ સાઈડથી કામ કરવાનું ચાલુ કરશે તો ધીરે ધીરે એ બ્રેન લેફ્ટ સાઈડને સ્ટ્રોંગ કનેક્શન તરીકે યુઝ કરશે, અડેપ્ટ થઈ જશે અને એ જ રીતે પછી એને સ્ટ્રોંગર એન્ડ સ્ટ્રોંગર ફંક્શનલ મુવમેન્ટમાં કન્વર્ટ કરી દેશે. સો ધેટ વે મેની કન્ડિશન્સ વી કેન ઓવરકમ ફંક્શનલી એન્ડ વી કેન મેનેજ ધ બેટર ક્વોલિટી ઓફ લાઈફ એઝ વેલ. આપણે એક વિડીયો જોઈશું હમણાં જેમાં તમને ખબર પડશે કે રેપિટેડલી કોઈ ચીજ આપણે શીખવી હોય, જેમ કે આપણે કોઈ સંગીત શીખવું છે તો પિયાનો શીખવું હોય તો પહેલે દિવસે જશું, ફર્સ્ટ ડે ઇટ વિલ નોટ ગોઈંગ ટુ બી લાઈક કે વી વિલ મેનેજ એવરીથિંગ, બટ ઇફ વિલ રિપીટ ઇટ એન્ડ ઇટ્સ ધ કરેક્ટ પેટર્ન વી વિલ રિપીટ ઇટ, એ કનેક્શન્સ બ્રેઇનમાં સ્ટ્રોંગ થશે. અને થોડુંક ટેકનિકલ છે એમાં કે કેવી રીતે સ્ટ્રોંગ થાય છે, પણ યુ વિલ સી ધોઝ ટુ વર્ડ્સ, એક્ઝોનલ સ્પ્રાઉટિંગ કે કેવી રીતે થાય છે બ્રેનમાં, અને યુ વિલ સી કે પ્રૂનિંગ કેવી રીતે થાય છે, એટલે કનેક્શન સ્ટ્રોંગ કેવી રીતે બને છે જેની ઇમ્પ્રેશન્સ બ્રેનમાં પડે છે. સો એ વિડીયો પરથી વધારે એમ્ફસિસ થઈને એકદમ બેસી જશે કે આ ચીજ આપણે ન્યુરોપ્લાસ્ટિસિટી કેવી રીતે યુઝ કરી શકાશે.
This song.
When we learn a new motor skill, the brain undergoes a number of changes. fMRI studies show blood flow increasing to large areas of the cortex involved in the task. The excitability of neurons distant to these regions heightens. And after weeks of practice, certain cortical maps representing the body parts being used enlarge to include adjacent previously uninvolved areas. These findings suggest a process we call plasticity, the brain's ability to change in response to our experiences, its ability to learn.
વિડીયો અત્યારે પ્લે થાય છે ને તો બધાને રિક્વેસ્ટ કરું છું કે તમારો ફોન કે ડિવાઇસીસ હોય ને એને જરા ખાલી મ્યુટ કરી દેજો તો બધાને સારી રીતે સંભળાઈ શકશે, ને તો અવાજ એકો થશે. થેન્ક યુ.
The supplementary motor area, also known as SMA, and the primary motor cortex, also known as M1, are the main areas involved in task learning. A highway of neural connections carries information from SMA to M1. However, many of these pathways are inhibited by signals from local GABAergic neurons that synapse densely around pyramidal cell bodies in M1. But disinhibition can occur. With focused repetition of a motor task, high-frequency activity is induced in thalamic projections to M1. And if input from SMA arrives at the same time, these inhibitory signals to the excitatory pyramidal cells of M1 diminish. Pathways once latent now activate the caudal part of SMA. And as practice of the task continues, activation spreads to the rostral area. Meanwhile, changes are also taking place in M1. Within M1, sprouting at axons and dendrites creates new synapses, or strengthens existing neuronal connections, resulting in greater complexity of the effective neuronal network. Pathways less used may be weakened through long-term depression, while those used most frequently may be strengthened through long-term potentiation. Several weeks of practice reveal growing representations of the body parts being used. Their boundaries, once considered static, begin to show overlap. As proficiency at the task increases, unnecessary neurons become inhibited. Cortical areas in M1, once enlarged, shrink to optimal sizes, and activation in SMA decreases. The brain is finding the most efficient use of space and neurons.
વિડીયો પોઝ થઈ ગયો છે જે સ્ક્રીનથી પ્રોજેક્ટ કરીએ છીએ that screen is been locked out એટલા માટે સો as you understood કે આ વિડીયોમાં એ લોકો શું બતાવવા માંગે છે હું આગળ પ્રોસીડ કરું છું ત્યાં સુધીમાં બીજી સ્લાઇડ પણ આવી જશે ઉપર ઓકે સો એઝ પહેલા આપણે વાત કરી પ્રમાણે જ કે જે કનેક્શન્સ છે ને સ્ટ્રોંગર બનાવવા હશે એ કનેક્શન્સ જો આપણે રેપિટેશન્સ વધારે આપશું તો એ કનેક્શન સ્ટ્રોંગ બનશે અને એવી રીતે જ આપણે પ્લાસ્ટિસિટી સાથે કામ કરશું તો નાના બાળકોમાં આપણને જે અડાપ્ટિવ રિસ્પોન્સીસ જોઈએ છે નાનપણથી જ એ કનેક્શન્સ આપણે સ્ટ્રોંગ કરી શકશું હવે જેવી રીતે અડાપ્ટિવ રિસ્પોન્સ છે ને એવી રીતે બ્રેન ઓલ્સો ઇઝ અકસ્ટમ ટુ ગેટ ધ adaptive plasticity as well એટલે બ્રેનમાં જેમ સારી ફંક્શનલ મુવમેન્ટ્સ રજીસ્ટર થાય છે એવી રીતે બ્રેનમાં માલ એડેપ્ટિવ પ્લાસ્ટિસિટી પણ રજીસ્ટર થશે સો ફોર એક્ઝામ્પલ કે કોઈ બી બાળકને જેને ડિસ્ટોનિયા હશે અને એ ઓવર યુઝ ઓફ ધ મસલ હશે તો એ બ્રેનમાં એ પેટર્ન રજીસ્ટર થશે એટલે એ જ પ્રમાણે પછી એનું ફંક્શનિંગ ચાલશે એને બ્રેકઅપ કરી અને એને પછી કરેક્ટ એડેપ્ટિવ પ્લાસ્ટિસિટીમાં નાખવી એ આપણા માટે થોડું એક ટાસ્ક થઈ જાય બટ અગેન બીકોઝ ધ બ્રેન હેઝ અ કેપેસિટી ટુ ડુ સો વી કેન ડુ દેટ એટલે એ બી આપણે અર્લી સ્ટેજમાં ડિટેક્ટ કરવી પડશે કે આ માલ એડેપ્ટિવ પ્લાસ્ટિસિટી બ્રેને ડેવલપ કરી છે સેકન્ડ પોસિબિલિટી છે કે આ માલ એડેપ્ટિવ પ્લાસ્ટિસિટી કેમાં ડેવલપ થઈ શકે ફેન્ટમ લિમ્બ સેન્સેશન ફોર એક્ઝામ્પલ કે કોઈને એમ્પ્યુટેશન થયું હોય તો જે બ્રેનમાં એ પાર્ટ રજીસ્ટર્ડ છે દેટ પાર્ટ આખો બોડીથી ડિટેચ કરી દેવામાં આવ્યો છે એટલે એ રજીસ્ટ્રેશન ઓફ દેટ પાર્ટ ઇઝ સ્ટીલ ધેર સો એમાં મુવમેન્ટ્સ થવું એમાં પેન થવું એ હજી હશે એટલે that will also be picked up by a maladaptive plasticity so એને બી બ્રેક કરી અને એના પર કામ થઈ શકે એમ છે that is the neuroplasticity suggest
And now it's this video.
Yeah. So there is another video we'll play for you. વિડિયો લઈ આવે છે, એક સેકન્ડ માટે રાહ જોજો. થોડી ટેકનિકલ પ્રોબ્લેમ છે, not the brain problem, so it's okay. So
Just write down your questions. Just
okay.
whatever questions you have.
If you have any question, so that will be nice. Just put it on the chat column and we will be able to answer those questions at the end of this sessions, okay?
So
Yeah. So just see this video. કે બ્રેન આપણું કેવી રીતે અડેપ્ટ થઈ જાય. એક તો માલ એડેપ્ટિવ કીધું ઈ અને બીજું કીધું કે નોર્મલ અડેપ્શનમાં બી.
Shaped by experience during childhood and adolescence.
બધા મ્યુટ રાખજો તો વિડીયોનો ક્વોલિટી સાઉન્ડ બરાબર આવશે. થેન્ક યુ.
But for most of the 20th century, scientists thought that the brain's malleability was lost by adulthood.
If that's true, then my brain now is the same as it was in that last picture when I was in high school, despite the years that have passed and all the experiences I've had since then. In 1913, neuroanatomist Santiago Ramon y Cajal wrote that the nerve paths are fixed, ended, and immutable. Everything may die, he wrote. Nothing may be regenerated. But we've learned a lot about the brain since then, and we're starting to realize that the adult brain is more dynamic than we ever imagined.
Our earliest understanding of brain development came from experiments on animals. Blocking vision in its eye early in life dramatically reduced the representation of that eye in the brain and could even cause blindness. But blocking an eye later in life had no such effect on the brain or vision.
So the same treatment that caused change in the young brain did not cause change in the adult brain. Then neurologists began to realize that large-scale alterations to the brain or body, such as traumatic injury, did cause changes in the adult brain. We'll come back to our unfortunate amputee in a minute. But first, how does the brain rewire itself? The neuroscientist Paul Bach-y-Rita illustrated this process with a metaphor about getting from one place to another. I need to get from my office here in brain mapping over to my seminar here in Haynes Hall, but I've got a problem. My usual route is blocked by construction. So how am I going to get to my seminar? Let's find out.
She begins by trying alternative routes. A similar rerouting process occurs in the brain after a traumatic injury. Just like a person finding a new path, the neurons affected by the injury rewire themselves. Some paths work better than others, and she gradually learns which route is the fastest. Once she does, this new route becomes her routine, and in a similar way, the brain's neurons form new connections.
This process by which the brain changes is called neuroplasticity.
If a person has a limb amputated, the brain still expects to receive sensory input from the limb. Neighboring parts of the brain reroute input to the areas representing the missing limb. So when other parts of the body, like the face, are touched, it can feel like a touch on the missing limb, creating a so-called phantom limb.
Major injuries can cause changes in the adult brain. What about more benign, everyday activities? Juggling that requires requires a unique combination of visual and motor skills to perform. A skilled juggler can keep track of several objects at once, throwing and catching each object with precision, constantly correcting small errors in the pattern. Could an activity like juggling change a person's brain?
Researchers in Germany taught adult subjects how to juggle and captured images of their brains in an MRI scanner as they became more proficient. Even after just 7 days, researchers found a measurable increase in gray matter in a brain region critical for visual movement recognition.
So it turns out that a brain-changing event does not have to be a life-changing event. And a universal type of experience, a person's culture, may shape the brain well into adulthood. Researchers in Switzerland followed American exchange students as they learned to speak German and found that learning a new language caused gray matter growth in the left inferior frontal gyrus, an area that's active during language processing. So what does this all mean? It means our brains are more dynamic than we ever imagined, even just a few decades ago. They have the potential for incredible recovery after injury, and they can be shaped by our experiences even in adulthood. All as the result of an amazing process called neuroplasticity.
સો આપણે જે રીતે વિડીયોમાં જોયું કે ન્યુરોપ્લાસ્ટિસિટીના કોન્સેપ્ટથી આપણે ઘણી બધી ચીજને અડેપ્ટ થઈ શકીએ છીએ એવી જ રીતે જેમ આપણને બ્રેનમાં ઇન્જરી થઈ હોય ફોર એક્ઝામ્પલ વી હેવ અ હેડ ઇન્જરી we have a head injury તો એક સાઈડમાં આપણને જ્યાં ઇન્જરી થઈ છે કે સ્ટ્રોક આવ્યો છે તો જેમ પિક્ચરમાં બતાવ્યું છે એવી રીતે પિક્ચર A અને B જ્યાં A માં રેડ કલરનું સ્પોટ છે that is the damage area and resulting in the loss of particular function but over a time જ્યારે opposite hemisphere can take over the lost function in the damaged hemisphere એ ગ્રીનમાં બતાવ્યું છે તો what happens કે each functions આપણે ફરીથી કરી શકીએ છીએ અને અડાપ્ટ કરી શકે છે એટલે જ્યારે સ્ટ્રોક આવે પેશન્ટને કે બ્રેન ઇન્જરી થાય ને તો this concept is very useful especially phantom limb as well જે આપણે વિડીયોમાં પણ જોયું કે phantom limb જ્યારે કે એમ્પ્યુટેશન થયું હોય ત્યારે બી આ જ પ્લાસ્ટિસિટીનો કોન્સેપ્ટ યુઝ થાય છે નાઉ વાય આ ચીજ છે જે ન્યુરોપ્લાસ્ટિસિટી એ અર્લી ઇન્ટરવેન્શનમાં કેવી રીતે આપણને હેલ્પફુલ થશે તો એના માટે બહુ સરસ એનાલોજી છે કે જેમ નાનું બાળક જન્મ્યું છે એનું બ્રેન બહુ સોફ્ટ છે એટલે એકદમ સોફ્ટલી અસેમ્બલ છે એકદમ હાર્ડ વાયર નથી થયું એટલે there is a lot of scope and lot of possibility કે આપણે એ ચીજને સારી રીતે ડેવલપ કરી શકશું હવે 85% of our brain growth happens postnatally એટલે બાળક જ્યારે બહાર આવે ત્યારે એનું 85% of the brain growth will take place so all the physiological basis for the recovery of these motor functions is distributed amongst the brain structure and processing levels rather than just the site of the lesions so this is very helpful કે આપણે motor function થી sensory function થી આ બધી ચીજને well develop કરી શકશું now જેવા new circuits આપણને જોઈએ છે તો એના માટે આપણને શું જરૂર પડશે focus attention emotional arousal અને repetitions આ ત્રણ ચીજ હશે ને તો નવા નવા circuit every day in the child we can develop અને they can cope up with the environmental stress as well as their physiological stress very well as well now relationships and interactions with the environment stimulates neural firing એટલે જેમ જેમ આપણે બાળકને કેર આપવા માટે જતા હોય we are the health professional who will go first to see the babies in the NICU કે પછી doctors nurses અને એના parents caregivers family members તો આ બધી ચીજ બહુ ઇમ્પોર્ટન્ટ છે કે આપણે બાળક સાથે interactions કરીએ અને એ લોકોનું જે એન્વાયરમેન્ટ છે એ પણ આપણે કેવી રીતે મેનેજ કરીએ કે જેનાથી એ લોકોના બ્રેન કનેક્શન્સ સરખી રીતે એડેપ્ટિવ વેમાં ફંક્શન થાય નાઉ બર્થ ઓનવર્ડ્સ ધ બ્રેન ઇઝ બીંગ રીમોલ્ડેડ એન્ડ શેપ્ડ બેઝડ ઓન અવર એક્સપિરિયન્સીસ થ્રુ આઉટ ધ લાઈફ એટલે જેટલું આપણે કન્ડ્યુસિવ એટમોસ્ફિયર આપશું જેટલું આપણે સારા સારા એડેપ્ટિવ ફંક્શન્સ અને સ્ટિમ્યુલેશન્સ આપશું એટલું આ બ્રેન મોટું થશે ત્યારે વેલ બેલેન્સ અને વેલ ડેવલપ થશે નાઉ દેર ઇઝ અ સ્પેશિયલ એડિશન ઓફ ધ ન્યૂઝ વીક, જેમાં એમ કીધું છે કે જ્યારે આપણે બાળક પાસે જઈએ, ધીસ ઇઝ વેરી પ્રેક્ટિકલ ફોર અસ. સો આપણે NICUમાં જઈએ ને બાળક પાસે, ત્યારે આપણે પોતે બાળક સાથે ઇન્ટરેક્ટ કરીએ, કારણ કે જેટલું આપણે બાળક સાથે ઇન્ટરેક્ટ કરશું, જેટલું બાળક સાથે આપણે હસશું, એને બોલાવશું, એને સાથે લલ્લબાઈ ગાશું, કે ખાલી સિમ્પલ ચીજ આપણે ખાલી રમીએ ને પીકબુ, તો એમાં બી કેટલું સ્ટિમ્યુલેશન બાળકના બ્રેનને મળે છે, અને એમાં એના જે બ્રેનના સેલ્સ છે ને એ ટ્રિગર થાય છે, અને એ ટ્રિગર થાય ને ત્યારે એમાં ક્રેકલિંગ, ઇટ્સ લાઈક અ લિટલ, જેમ કીધું ને ક્રિસમસ લાઇટ કેવી રીતે હોય એવી રીતે થાય, અને બાળકનું બ્રેન ડેવલપ એટલું બધું સરસ રીતે થાય કે આખું એન્વાયરમેન્ટ દે પરસીવ ઇટ વેરી વેલ. So along with this particular giggles and stuff, તમે બાળકને ટચ કરો. If you give a soft touch, you know, with the hands, with cloths, or just ઈ બાળક એને પકડે, એને છોડે, એને ડ્રોપ કરે, ઓર સિમ્પલ ચીજ એના મોઢા પર ખાલી કપડું નાખો અને આમ આખું ઈ કપડું કાઢી લો, તો એનાથી બી એને ઘણું બધું બ્રેનને સ્ટિમ્યુલેશન મળશે, અને જેનાથી એના સર્કિટ્સ બહુ સારી રીતે ડેવલપ થશે. સો આ બધી ચીજ આપણે નર્સિસ, આપણે ડોક્ટરો, થેરાપિસ્ટ, જ્યારે આપણે બાળકને જોવા જઈએ કે બાળક તમારી પાસે OPDમાં આવે ને, તો આ સિમ્પલ ઇન્ટરેક્શન્સ ઇઝ વેરી ઇમ્પોર્ટન્ટ, અને આ બહુ પ્રેક્ટિકલ છે, જે આપણે કોઈ બી નાના બાળકને સહેજે જોઈને જ કરતા હોઈએ છીએ. સો મેક શ્યોર કે તમે આ ચીજ વધારે ને વધારે ડેવલપ કરો. હવે નેક્સ્ટ સ્લાઇડમાં આપણે જોઈશું કે એક એક્સપેરિમેન્ટ કરવામાં આવ્યું હતું, કે જેમ પાયલબેને એમના પ્રેઝન્ટેશનમાં કીધું કે જ્યારે બાળક નાનું હોય અને ત્યારે જો એને બરાબર અટેચમેન્ટ ન મળ્યું હોય અને એને નિગ્લેક્ટ થયું હોય તો શું રિપર્કશન્સ આવી શકે છે. એના માટે એક રોમાનિયન ઓર્ફન જેના પર આ એક્સપેરિમેન્ટ થયું હતું, તો એના બ્રેનની સ્ટડી કરી અને એનું જે ઇમેજ વર્ષનું હતું, તો એક આપણે જોઈએ કે નોર્મલ બ્રેન છે ઓન ધ લેફ્ટ સાઈડ, અને એક રાઈટ હેન્ડ સાઈડ છે કે જે બ્રેનમાં એક્સ્ટ્રીમ નિગ્લેક્ટ એ ચાઇલ્ડને મળ્યું હતું, તો કેવી રીતે ડેવલપ થયું છે. સો ઇફ વી કેન સી કે રાઈટ સાઈડનું બ્રેન છે ને એ સ્મોલ છે ઇન સાઇઝ, એટલે ઓલા નોર્મલ કરતા નાનું છે. પછી બીજું છે કે એના વેન્ટ્રિકલ્સ છે ને એકદમ ડાયલેટેડ છે, એટલે એકદમ જે આપણને બ્લેક હોલ્સ કેવિટી દેખાય છે એ મોટા છે, અને પ્લસ જે સાઈડનું કોટેક્સ છે વિચ ઇઝ અ વેરી 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 ઇમ્પોર્ટન્ટ પાર્ટ ઇન ધ હ્યુમન ધીસ થિંગ, કે જેનાથી હાયર કોગ્નિટિવ ફંક્શન્સ ને બધું ડેવલપ થાય, ઇમોશન્સ, ઇમોશનલ સ્ટેબિલિટી, બાળકની પર્સનાલિટી ડેવલપ થાય, એ આખું કોર્ટેક્સ એરિયા શ્રંક થઈ ગયું છે. એટલે આગળ જતા એ બાળકને કેટલી બધી ડિફિકલ્ટીઝ ફેસ થશે ને એ આપણે આના પરથી જોઈ શકશું. હવે આ જે ન્યુરોપ્લાસ્ટિસિટી છે એ આપણું કોન્સેપ્ટ એ કેવી રીતે આવ્યું છે, તો દેર આર લોટ્સ ઓફ સ્ટડીઝ એન્ડ એક્સપેરિમેન્ટ. તમે જોશો ને તો તમને ઇન્ટરનેટ પર, જર્નલ્સમાં બધે જ ઘણી બધી ચીજ મળી આવશે, બટ દેર આર સ્પેસિફિક થિંગ્સ વિચ દે હેવ ડન. કંટ્રોલ એન્વાયરમેન્ટમાં એ લોકોએ રાખીને આ ચીજને સ્ટડી કરી છે, અને ઇટ ઇઝ બીન પ્રૂવન. થોડીક સ્ટડીઝ અમે લોકોએ જે આમાં લીધી છે એ જ હું ખાલી કહું છું, કે એક જે સ્ટડી કરી હતી એમાં એ લોકોએ રેટ્સ પર સ્ટડી કરી હતી, કે ઈ રેટને એક બે ગ્રુપ ઓફ રેટ પાડીને એના પર સ્ટડીઝ કરવામાં આવ્યું હતું, કે એકને બરાબર એકદમ નિગ્લેક્ટ કરે ને એકને વ્યવસ્થિત રાખવામાં આવે, તો જે વ્યવસ્થિત રાખેલા છે એનું બ્રેન કેવી રીતે ડેવલપ થાય, એ લોકોને એન્વાયરમેન્ટલ સ્ટિમ્યુલેશન મળે તો એ લોકો કેવી રીતે ડેવલપ થાય, અને બીજું હતું જે નિગ્લેક્ટેડ છે, જેને બરાબર રાખ્યા નથી, પુઅર કન્ડિશન્સ, પુઅર એન્વાયરમેન્ટ, ઇન્ટરેક્શન્સ નહીં, તો એનું બ્રેન કેવી રીતે ડેવલપ થાય. બીજું સ્ટડીઝ કરવામાં આવ્યું હતું કે જેમાં CNS પ્લાસ્ટિસિટી એવિડન્સ ઇન મંકી, કે એ મંકીના જ્યારે ડિજિટ્સ 3 ડિજિટ એમ્પ્યુટ કરવામાં આવ્યા, તો એ મંકી કેવી રીતે એ ડિજિટ એમ્પ્યુટ કર્યા છતાં પણ ફંક્શન્સને કેવી રીતે ગેઇન કર્યું. સો એના બ્રેનને સ્ટડી કર્યું તો ખબર પડી કે બિકોઝ ધ બ્રેન હેઝ અડેપ્ટેડ ઓલરેડી, કે જે લોસ ઓફ ડિજિટ્સ હતા એના બ્રેનમાં ભૂસાઈ ગયા, બિકોઝ જે બીજી સાઈડથી હેન્ડ કામ કરવું જોઈએ એ હેન્ડથી એણે સ્ટાર્ટ કરી દીધું હતું. So these are the small evidences which shows that our brain has a beautiful capacity to adapt. Now, how do you change the plasticity of the brain? આ એક ફંક્શન છે ને જેના માટે થઈને આપણે આખી આ ચીજ આજે કરી છે, કે આપણા બ્રેન પાસે એડેપ્ટ થવાની બહુ બ્યુટીફુલ કેપેસિટી છે. એટલે આપણે બાળકને જ્યારે નાના હોય ત્યારથી જ આપણે જો એની સાથે એન્વાયરમેન્ટ અને રિલેશનશિપ વાઇઝ એવું ઇન્ટરેક્શન કરીએ તો એના બ્રેનને આપણે એડેપ્ટ કરી શકીએ. સો તમે જોઈ શકો છો, ફોર એક્ઝામ્પલ જે બ્રેનના હેમિસ્ફિયર છે એમાં કોર્ટેક્સ છે, એમાં સેન્સરી કોર્ટેક્સ છે અને મોટર કોર્ટેક્સ છે. એટલે સેન્સરી અને મોટર બંનેમાં સેમ ઇમ્પ્રેશન્સ ઇફ યુ કેન સી એકદમ આ મિરર ઇમેજ કેવી રીતે હોય એવી રીતે છે. So exciting the sensory and motor system to enrich the internal representation of the body scheme. એટલે જેટલું તમે બોડી સ્કીમ એ બાળક સાથે એના બોડી પાર્ટ્સને ટચ કરીને એના બોડી પાર્ટ્સની સાથે રમીને જેટલું સ્ટિમ્યુલેશન સેન્સરી દ્વારા તમે આપશો એટલું જ એનું મોટર કોર્ટેક્સ પણ વેલ ડેવલપ થશે. પછી movements like reciprocal kicking, grasping increases the representation in the body scheme. એટલે જેટલું આપણે મિડલાઇન થી શિફ્ટ થઈને કામ કરશું એટલે બંને હાથ પગ ને હલાવવા, બંને હાથ પગની એક્ટિવિટી કરાવી, ક્રોસ આર્મ્સ કરાવવા, આપણે બાળકની સાથે રમીએ ત્યારે હાથને ક્રોસ કરીએ, પછી એને વેવ કરતા શીખડાવીએ. સો દેટ ઇઝ અગેન અ ક્રોસ લાઇન ચેન્જ કરીએ. એમાં સિમ્પલ ટાસ્ક છે, એને કહીએ કે તમે ઇમિટેટ કરો આપણને. સો ઇફ વી જસ્ટ લુક એટ ધેમ એન્ડ વી જસ્ટ મેક સમ ફેસીસ, કે એ લોકો સામે જોતા આપણે એ લોકોને વેવ કરતા શીખડાવીએ તો આ નાની ચીજ પણ એ લોકોના બ્રેનને ડેવલપ કરવામાં હેલ્પ થશે. જેમ મેં પહેલા બી કીધું કે ખાલી એક નાનકડું તમે બાળક આવે અને એને કપડું એના મોઢા પર આમ મૂકો અને પછી ધીરેથી કપડું આમ ખેંચો, કે બાળકને જ કહો કે એના હાથેથી કપડું ખેંચે, તો ધીસ little thing also gives lot of sensory stimulation અને બોડી સ્કીમ એ લોકોના બ્રેનમાં પોતાની બોડી સ્કીમ એ લોકોના બ્રેનમાં ઇમ્પ્રિન્ટ થશે. અને જેટલા જેમ આપણે પહેલા કીધું કે કનેક્શન્સ અને મુવમેન્ટ્સ આપણે સ્ટ્રોંગ કરવા હોય એટલી મુવમેન્ટ્સ પેટર્ન્સ વધારે આપશું, એ કનેક્શન્સ બ્રેનમાં વધારે સ્ટ્રોંગ રીતે ઇમ્પ્રિન્ટ થશે. હવે just to summarize everything, last few bits, our brain have a lifelong ability to adapt and build. એટલે આનો મતલબ એમ છે કે આપણે જેટલું બ્રેનને વાપરશું ને એટલું એ સારી રીતે કામ થશે, એ ખાલી નહીં થઈ જાય, એટલે વાપરજો. That's very good. So અને these neural information highways from the basis of our cognitive skills, એટલે જે આપણું આગળ જતા કોગ્નિશન ડેવલપ થવાનું છે એના માટે નાનપણમાં આપેલા ઘણા બધા ઇન્ફોર્મેશન્સ, એટલે ઘણા બધા જે આપણે એન્વાયરમેન્ટલ સ્ટિમ્યુલેશન એ લોકોને આપ્યા હશે ને એ બધું હેલ્પ કરશે. કોગ્નિટિવ સ્કિલ્સ આર નોટ ઓનલી રિપ્રેઝેન્ટેટેડ બાય ધી IQ, but it also comprises how efficiently we are able to process information in every areas of life. So that is very important. Because the brain is always adapting and building, our ability to think, remember and learn is never static. એટલે આપણે હંમેશા આપણી લર્નિંગ ચાલુ જ રહેશે. It can always be upgraded and improved. So please, when you see these babies in NICU or તમારા ક્લિનિકમાં આવે કે તમારા હોસ્પિટલમાં આવે, as much as you can interact with the babies, as much as you can give a sensory motor inputs, that will be very useful and that will develop the lot of good connections in the brain. This will end the talk. Thank you very much, everyone. If you have any questions, I would request please post it on the chat box and we will tackle all the questions at the end of the presentation.
Thank you so much, Dr. Neha. And as she said, very fantastic presentation. So please, participants ne koi questions hoy to તમે chat box માં જરૂર લખી શકો છો. So now we will move on to the third presentation, which is epigenetics, which will be delivered by Dr. Bansi. Dr. Bansi, she is a practicing physiotherapist and she is a certified neurodevelopmental physiotherapist and in sensory integration and also in aquatherapy. And she has an experience of more than 7 years. So over to you, Dr. Bansi, for epigenetics.
Good afternoon, everybody. We just had 2 wonderful PPTs and you all are ready for the second last PPT, I hope. So now the topic is epigenetics. Epigenetics is a very new research topic and it's been coming up a lot in research. So we thought we should take this so that everybody is aware about this. And a lot of studies on all these disorders like ADHD, autism, learning disabilities. એમાં બહુ બધી studies ચાલી રહી છે કે does genetics and how genetics does have a role to play in all this, because now with the NICUs we are having a very high survival rate, which is very good that babies are surviving, but the intact survival is more important. So in the process of saving the child, we are seeing the increased number of diseases like ADHD, autism, learning disabilities, etc., which are coming up. So the child is motorly maybe normal, but he's having all these disorders which are caught much later. Once the school teacher complains, once the mother has seen like, okay, now he's not being able to cope up in school, ત્યારે જઈને આપણને આવે છે. So why we are learning about epigenetics is to prevent it from the base, and we can catch it early. Okay, so self-regulation was mainly so that we can catch very early and prevent it from the NICU days. Epigenetics is one step before that also, how we can do it while prenatally also and postnatally also, both, but prenatally also how we can prevent those genes from being expressed. Okay, so let's go on. તો હવે શું છે એપિજેનેટિક્સ એટલે શું? સો એપિજેનેટિક્સ literally means above or on top of genetics. It refers to external modification of DNA that turns gene on and off. એટલે તમારા આપણા બધામાં છે ને there are a lot of genes present. એટલે આપણામાં કેન્સરના genes છે, autismના બી genes હશે. હજી સુધી it's not been researched that which particular gene is responsible for autism, but when they are studying autistic kids, they are finding newer expressions of the genes every time they are seeing a different autistic. તો હજી એક કોઈ રિસ્પોન્સિબલ નથી, બટ સે ફોર એક્ઝામ્પલ કેન્સર છે, ડાયાબિટીસ છે, આ છે, there are a lot of hereditary disorders. When they are seeing those, what caused that gene to get expressed? So even if I have a cancer gene, it's not expressed in me, but in some it's expressed. So what caused that cancer gene to express itself is by epigenetics we will know. Okay, so now these modifications do not change the DNA sequence, but instead they affect how cells read genes and express themselves. It is a regular and natural occurrence, but it can be influenced by a multitude of factors. એટલે આ genes જે express થયા, say for example autism ના, say for example cancer ના, ઈ કયા કારણે express થયા, કેમ ઈ activate થઈ ગયા? તો એમાં number of factors responsible છે. For example age, environment, lifestyle and a disease state. So epigenetic modifications manifest as commonly as cells differentiate into skin cells, brain cells, liver cells. હવે આપણે જ્યારે fetus હોય ને પેટમાં, ત્યારે આપણા cells divide થતા હોય, ત્યારે ઈ specific DNA નું protein, it manifests into a brain cell, it manifests into a kidney cell, it manifests into a liver cell. એવી રીતે જ એક cell manifest થઈ ગયું જે got it responsible for the production of cancer cells, for the production of autistic features in the brain cell. એટલે ઈ એવા cells differentiate થઈને manifest થયા. So what caused that manifestation? It can be when the child is in the womb, it caused that manifestation, કે ઈ કોઈક that we will just see it ahead how it got manifested. Okay, let's go next. So autism and autism spectrum disorders are complex neurodevelopmental disorders characterized by dysfunction in social interaction, communication, restricted interest, ઈ પોતાના જ શેલમાં રહેશે બાળક, repetitive stereotypic behavior. એટલે ઈ એનું એજ એને એજ સ્કેડ્યુલ એમાં થોડુંક બી ચેન્જ આવી ગયું કે એને સેલ્ફ repetitive behaviors હશે જેનામાંથી એ બહાર નહીં નીકળી શકે. તો ઈ signs છે autism and autism spectrum disorders na, it seems likely that epigenetic dysregulation might contribute to significant proportion of ASD cases, yet no single gene can account for more than 1% of the cases of ASDs. એટલે ASD નું એક કારણ epigenetics છે. There are lot of કારણ, બહુ બધા કારણો છે. But if the child is neglected in early days, if it is orphanage and a social interaction onu nahi malyu, jena karane did not learn, so EB can lead to future autisms. But one of the reasons can also be epigenetics. So let's see how it can cause. Have epigenetics on mood. depression. હવે એ કેવી રીતે થયું? The effect of early stress and a gene environment interaction may play a role in development of stress vulnerability as a risk factor for depression. Evidence suggests that genetic predisposition interact with the environment in potentiating depression. In the brain, these changes might be reflected in differential functional connectivity between areas, including the hippocampus, as a function of life stress. હવે આ શું થયું કે, for example, in early life there was some stress. હવે E gene activate થઈ ગયું, which causes depression. Okay, so once it causes depression, so what happens? That activated gene, while the child is in the mother's womb, હવે ઈ મધરમાં સપોઝ એક્ટિવેટ થઈ ગયું ઈ ડિપ્રેશનનું જીન, સો દેન ધેટ જીન કેન ગેટ પાસ્ડ ઓન, કેમ કે ઈ એક્ટિવેટેડ જીન જ છે એટલે ઇટ વિલ ગેટ પાસ્ડ ઓન ઇનટુ ધ ચાઇલ્ડ, એન્ડ ધ ચાઇલ્ડ કેન હેવ ડિપ્રેશન very early, very quickly, or is very high chances will have depression. Okay, so we want to prevent the expression of these genes from early on. From whichever generation we can stop the expression of these genes of depression, of autism, then it is great. So we have to know what is causing the expression. Let's go. So, હવે prenatal and perinatal environmental challenges during the course of pregnancy are likely causes of delirious epigenetic modifications to the fetal brain with long-term developmental sequences, including risk and to autism spectrum disorders. હવે prenatally the mother had higher level of say cortisol for any reason. Say pregnancy માં complication હતી, there were family issues, there was environmental stress, હમણાં COVID ચાલી રહ્યું છે. So very high chances that those people will be in stress who are going to be delivering babies, who are going to come to the hospital. હવે આ cortisol has the capacity to express those genes which can be responsible for a lot of diseases. Say for example autism, say for example ADHD, say for example learning disability, or any of those causes can get expressed. હમણાં હજી કાંઈ કહેવાતું નથી કે everything is genetic, but autism has a very high rate. So those genes can get expressed if this cortisol level is very high. That chemical can cause the expression. Prenatally this was. Even if the genes may not be only cause of someone's autism, they can still contribute. So it's important to get the best possible information about the child's genetic. So it's one of the causes. As we said, it's not the only cause. Let's go next. હવે genes only set a stage. હવે આપણા બધામાં એ genes છે, okay, but they're not, all of them are not activated. The disease that we don't have, ઓલા જે disease આપણને નથી, એ genes આપણામાં activated નથી. So genes are a living document that changes over the course of your life, influenced by the air you breathe, the food that you eat, and the experience and the exposure that you have. So you are not actually affecting function but the DNA. So what happens as therapists, when we are working on a child, or we are as doctors, when you all are working with while you all are doing in the NICU, or even prenatally, when you are seeing those mothers, their emotional health, when we show that love, that compassion, that empathy, or we even reduce medically some stress on the child, તમે એને ઓલા પેન માંથી ઓછું કર્યું ને, એના રીતે એને મેન્ટલ સ્ટ્રેસ ઓછું પડ્યું, એના રીતે ઓલા chemicals of cortisols etc did not get increased in the brain, એના રીતે એના gene expression જે autism કે કાંઈ create કરત, ઈ નહીં થયું. So you are not changing by giving a good therapy, by giving just a listening here, or you are just being with the child, happily being able to play and not adding stress. Suppose child is say is deformed or is having that, and so, I mean positively if you can work with the child, then you're not changing only the function. એ function તો achieve કરશે તમે જેના ઉપર કામ કરી રહ્યા છો, ચાલવું, બોલવું, શીખવું, જે બી. એ લર્નિંગ ડિસેબિલિટી છે તો તમે એના લર્નિંગને ઇમ્પ્રૂવ કરવાનું એક ગોલ છે, પણ ધ ચાઇલ્ડ્સ positive mental health is very important. Because in positive mental health, so you're preventing so many genes from being expressed, which can cause a lot of disease in the future, in the child and in a next generation. पर भी ये effect करी सके. So you're not only changing function, you're changing the DNA. You're changing this generation and the coming generations. If you're working beautifully in a positive thing. એટલે જેમ પાયલે, ડોક્ટર પાયલે લીધેલું self regulation નું PPT why we are saying that we should start so early, have engagement with the child, क्योंकि ये जो positive influences चाहिए automatically तुम्हारा sympathetic nervous system ने cut down करे, cortisol levels ने cut down करे, जे आ genes ने express करवानु कारण बने છે. Okay, let's go next. Now mutation can happen. હવે આ મ્યુટેશન કેન હેપન ડ્યુરિંગ પ્રેગ્નન્સી. આપણે શીખ્યું કે ઈ જ્યારે સેલ્સ મ્યુટેટ થતા હોય ડ્યુરિંગ પ્રેગ્નન્સી. સો when cells are producing rapidly or as a part of aging, when damage accumulates, some of these mutations appear to be generated by repetition or deletion in genetic code. Sometimes genes that aren't a problem for the parent become one problem for the child born and raised under different condition. For example, child ne mother ne એવું કઈ હતું નહીં, but the child got a problem. Why it happened so? Say the child was having diplegia or some sort of motor difficulty. જેના રીતે એનું stress increase થઈ ગયું. There was a lot of pressure from the side of performance કે આવી રીતે છે, social stress થઈ ગયું. એના રીતે એના કોઈ બીજા genes બી express થઈ શકે, જે can cause further diseases. Okay, so those diseases we can prevent from being expressed કે પેરેન્ટમાં નહીં હતું પણ ચાઇલ્ડમાં સ્ટ્રેસ હતું ને એના રીતે એનામાં એ જીન્સ એક્ટિવેટ થઈ ગયા અને હવે that child can become a carrier for his next generation. Go next. Many sites in the human genome are modified through the addition of methyl groups to the DNA. Are difficult nothing, we'll just understand it in short. Such methylation can dictate whether a particular gene will get expressed. હવે આ જે પ્રોસેસ છે ને કે આ જીન ટર્ન ઓન થઈ ગયું, સે એવી રીતે સે ડિપ્રેશનનું જીન ટર્ન ઓન થઈ ગયું, તો એ ટર્ન ઓન કેવી રીતે થાય છે? બાય અ પ્રોસેસ ઓફ મિથાઇલેશન. હવે ઈ મિથાઇલેશન કેમ થાય છે? એટલે મારામાં જો સપોઝ ડિપ્રેશન નથી તો મતલબ ઈ મિથાઇલેશન ઈ જીનનું નથી થયું. So what is causing that methylation? There are a lot of causes, like say chemicals of cortisol, sympathetic nervous system થી જે બીજા stress chemicals activate થાય છે, those are the karan for this methylation to occur. Okay, so and there is environmental factors, the air that you breathe, the food that you eat, આ બધાના અંદર જે toxins કે જે હોય જેના રીતે ઈ મિથાઇલેશન થઈ ગયું તો પછી એ ડિઝીઝ વાળું જીન એક્ટિવેટ થઈ શકે. Let's go next. Similarly, there is glutathione જે express થઈ જાય છે when the autism gene is being expressed. So this the researchers have found out, Jill James કરીને એક researcher હતું that found higher rates of glutathione in autism because this gene was expressed. The autism gene was expressed, એનાથી higher level of glutathione was found out. So now we have our genes, are the environmental lifestyle, and then it represents the child. So now the genes, okay, so genes આપણા બધામાં dormant રીતે છે. હવે your lifestyle, the mother's lifestyle, the lifestyle of the child, or the environmental factors in the NICU, એનાથી it can determine કે some genes which were dormant can get activated and it will lead to a new child with a disease or without a disease. It depends. So dormant genes to છે, એના lifestyles અને environment factors will play a role to get this human with which all genes are activated in him. Let's go next. Now this was a study of World War II Dutch famine. એમાં શું થયું કે જ્યારે famine હતું ત્યારે lot of people had starvation. So because of that starvation, એ લોકોના છોકરાઓ ફ્યુચરમાં જોવા આવ્યા કે એ લોકોના જ્યારે છોકરાઓ થયા they were obese. So why did this happen? Because they were starving. એ લોકોનું જે જ્યારે child was being born, they had constant mind in constant brain of saying that they had a want of food. So when the child was being formed, cells, okay, when they were differentiating into the brain cells, they also got differentiated with that want of food gene to get activated. So when that DNA or that RNA got, that protein got activated, the want of food, those children ate a lot. So it caused obesity. So this is a basic overview of epigenetics. There's a lot of research going on. This is just to open the eye કે newer research and આપણા kidsમાં જે autism ને બધું જોવામાં આવે છે એમાં this also has a role to play and how we can prevent it early. Okay, so we end over here. with our PPT, and Dr. Gorich can take over from here. Thank you. If you all have any questions, you all can put it in the chat box.
Yeah, thank you so much, Dr. Bansi. So I think with your presentation, we got a very good gist of how exactly we are going to, the future will be shaped with regards to epigenetics. So any questions, please put in the chat box. Now we'll move ahead with two very good videos. કે જેમાં we have NICU માં આપણે કેવી રીતના therapy and early intervention થી there was a life changing experience for two of our kids. Although we have many success stories, but we would like to share a few success stories with you all. Ki early intervention thi આ લોકોને how the improvement came clinically and how their world has been changed now. So I think I would request our team to show those two videos so that you get a good knowledge that NICU માં આપણે ભેગા મળીને as a team, if we work, what wonders we can do together. Over to you, Dr. Pat.
Yeah, thank you, sir. Okay, now basically. Okay, yeah, as Dr. Gorge rightly said, we are going to play a video of a child in the NICU, and I would like you all to observe there are these captions there so that we don't stop the video and we are not talking with it. So you can just observe it well, and there are very small things which only few of the things we have added in the intervention right now. So you can just see it, and then again I would really like if you all give some questions on it so that we know that you've perceived it or not, so that just let's go to the video and we'll play we have many videos. We are starting with this one. Okay.
Born preterm at 8 months through caesarean section at a private hospital in Surat, Kunj merely weighed 1.5 kgs. As an added complication, doctors diagnosed him with septicemia and birth asphyxia. Kunj was soon admitted to Shrimad Rajchandra Hospital's neonatal intensive care unit, where he was monitored and stabilized. During the 15-day stay, he was treated for acute lower respiratory tract infection with respiratory distress syndrome, septicemia, and shock. Breastfeeding was done in the NICU to minimize the stress associated with mother-infant separation. Post-discharge from NICU, a home program was designed to ensure recovery. Practices like tummy time, parental interaction, and skin-to-skin contact were recommended. In the 3rd month evaluation, he still showed delay in his developmental milestones. After a thorough evaluation by specialists at Shrimad Rajchandra District Early Intervention Center, he was diagnosed with global developmental delay. Ultrasound imaging of the brain suggested small lacunar infarcts along caudothalamic grooves, mild white matter volume loss, with mild excavodilation of lateral ventricles on either side, along intraventricular hemorrhage. Thus, a multidisciplinary approach was used to devise a treatment plan. His mother was taught physical therapy techniques like positioning and handling. Soon Kunj learned to cope with the stressful situation through self-regulatory mechanism. After extensive occupational therapy and sensory integration interventions at Shrimad Rajchandra District Early Intervention Center, Kunj has been able to perform gross motor activities, fine hand movements, independent transitioning to a different surface, has overcome gravitational insecurity, following commands, જલ્દી ઊભો થઈ જા. ઊભો થઈ જા. Activities of daily living. Problem solving. Identifying colors. Concept training. બીમાર હવે આ શું છે? આ શું છે? ઘેર. તારું ઘર ક્યાં છે? હા. સુથવાડ. સુથવાડ. અરે વાહ, તને તો સુથવાડ પણ ખબર. Developmental quotient test at 13 months of age showed gross motor development of 8 months, language development of 10 months, fine motor development of 11 months, and social and personal development of 11 months. Developmental quotient test at 38 months of age showed gross motor development of 34 months, language development, fine motor development, and social and personal development of 35 months. With the grace of Shrimad Rajchandra ji and blessings of Pujya Gurudev Shri, many children like Kunj are now able to live a normal and healthy life due to the care provided at Shrimad Rajchandra District Early Intervention Treatment Center.
So that was a life-changing transformation.
All right,
which we
so
could
this is
see.
one of the example
Yeah,
of a child in the NICU, and it was with us from the NICU, and how we followed him up on a regular time, and then did the intervention at the right time, gave the mothers that handling techniques, positioning techniques, so that they don't have to always all the time come to us, but they can follow up on a regular this thing. So generally what happens is that we decide about discharge of the child in the early intervention clinic, that physical development ho gaya hai, chalo, the child is walking, looking all fine, doing all well, and then we think that it's okay, but it's very, very important to know that again, when we spoke about the cognition development, so you could see, we especially kept those slides and those shots to make you all understand that self-regulation kyare ene આવ્યું, એને ક્યારે cognition આવ્યું, how he started following commands, how he did problem solving. So all that also becomes important, because that's going to be the learning for him later on. So with sensory integration, with cognition, with these mechanisms of regulation, the child is getting a complete setup of how to deal in the future. So we have one more video. It's a very interesting video. It's about Salvi. There are twin sisters, Salvi and one the sister, and she is having some major cortical visual impairments, and it's very beautiful that how she's come up with NICU, how she followed up, how she underwent a real vision therapy, and with that she had a sensory integration therapy, neurodevelopmental therapy. So we'll just see that video.
Sure.
Meet Selvi Patel. Born premature at 29 weeks, Selvi and her twin were conceived to a high-risk pregnancy by a diabetic mother. At 5 months of age, her family reached out to Shrimad Rajchandra Hospital, where she was diagnosed with birth asphyxia and respiratory. Meet Selvi Patel. Born premature at 29 weeks, Selvi and her twin were conceived to a high-risk pregnancy by a diabetic mother. At 5 months of age, her family reached out to Shrimad Rajchandra Hospital, where she was diagnosed with birth asphyxia and respiratory distress syndrome grade 2. She was admitted in the neonatal intensive care unit for 57 days, where she was continuously monitored and stabilized. She came to Shrimad Rajchandra District Early Intervention Center at 5 months of age and showed a lack of head control, lack of eye contact and visual tracking, and a delay in social smile. She also presented momentary nystagmus and severe crying with a poor bilateral reach. She was diagnosed with global developmental delay, along with cortical vision impairment and sensory processing disorder in the systems of tactile, vestibular, and proprioception. A thorough treatment plan with a multidisciplinary approach was devised. Along with the interventions for motor control, she also underwent laser therapy for retinopathy of prematurity. Soon, she could reach for a toy and play with it. Today, she is able to sit independently and stand and walk with mild assistance. With the grace of Srimad Rajchandraji and the blessings of Pujya Gurudev Shri, such access to high quality holistic rehabilitation and physical therapy is ensuring that the district of Valsad move towards becoming disability free.
Which video? All right. So as we saw Salvi, so she underwent a comprehensive therapy of neurodevelopmental therapies, sensory integration, vision therapy, and see how she came up with her functions. And it's very beautiful to see that, so what exactly what we want to do right now is we want to take back something which you all can do in the NICU. So we'll also play a video where you can see what small things, like we were talking about the cell regulation mechanism and everything. So that if you all want to take back, we'll just show you a small video of that as well. What we exactly do in the NICU, there are a few techniques that are being mentioned in the NICU as therapists, as nurses. If we can start, taking that and start doing that till further we know about the treatment, we'll just go and give a treatment video to you all, and then we can discuss. All right. So just like a summing up for what we spoke till now. So if you can see in this video, there were various states of regulation that the baby is showing. So if you saw that the baby was initially say he was in a stress position of a arching posture, and then slowly the intervention started. The baby started communicating through cry, which is also important because it was that time when we started he was still in a deep state, and then slowly he's coming to the crying state. Then post that it was comfortable, it was being we are rocking the child, we're giving self-regulatory mechanism of giving hand to mouth, doing a talk to the child, calming the child with positioners, then also giving the mothers. If you'll notice, there was a dupatta of the mother, so the mother's dupatta has been given to the child, where the child has a feeling of security, as well as there's olfactory stimulation, where the mother's dupatta, so it's been kept with mother for a night, and then it's been given to the child, so the child perceives the smell of the mother. So that all those things were shown in a way so that the child regulates from a stress behavior, slowly communicating, doing a cry, to a quiet behavior. So just if you can remember the states of regulation, so we spoke about those regulatory states. So easy transition of those states become important for the child slowly. And this is what is being practiced here. And a few of the techniques we would want you all to take back home and start in your NICUs. So I would now request Dr. Gorage. Dr. Gorage, our videos have been played, so you can
Sure.
you can start with your presentation.
Yeah.
Thank you so much.
Yeah. So thank you, team. So now coming on to the last presentation, and again I would request that please put on your questions on the chat box if at all available, because once we finish the presentation of the last one, I mean, we can discuss those if we have the time. So coming on to the presentation, I'll be mostly talking about the role of the each team member which we have seen, because treating the babies and all the newborns is not a task of a single person. So it's a complete teamwork which we have to see and which we have to follow. So I'll be briefly talking about the role of each and every team member in the NICU per se. So as I said that the babies, it's a completely different environment for the baby once he comes out from the womb of mother. So it can be both frightening. એટલે બાળકને જે કઈ બહાર જ્યારે આવે એ મધરની બહાર, રૂમના બહાર, તો ત્યારે એમના માટે કાં તો ગભરામણ જેવી પરિસ્થિતિ થઈ શકે, કાં તો રીએશ્યોરન્સ જેવું આપણે આપી શકાય. So it is in our hands. It is in our hands to what kind of environment which we can give it to him. So a new baby is like a beginning of all things. It can be a wonderful beginning. It can be a dream of possibilities and a dream of hope. So NICU it exemplifies કે એક interdisciplinary approach રહેવા જોઈએ, અને બધા ભેગા મળીને જ્યારે બાળકના વેલબિંગ માટે કામ કરીએ ત્યારે જ આ બધા જેટલા આઉટકમ્સ આપણે વિડીયોમાં જોયા હતા that we can achieve. So who is a part of the team? It consists of the professionals like doctors, nurses, the nutritionists, the physical and occupational therapist, a psychologist, the ophthalmologist, optometrist, speech therapist, obstetrician gynecologist, and the allied people like social worker, ASHA worker, Arogya Sahili, and of course patient's family and the mother, who is of utmost importance. So the outcome of a baby who is admitted in the NICU is completely dependent on the teamwork of all these people who I have mentioned. So the neonatologist or the pediatrician is the primary caregiver or the primary doctor of the child who is admitted for some other sick cause like a birth asphyxia, sepsis, or birth defects. So he has to basically diagnose the baby and give the treatment protocol, and he has to maintain and ensure that the child receives proper treatment and ensure the proper outcome of the child. So here is Dr. Yogendra is also, it can be seen here, and we also have Dr. Devang, who are a part of our pediatrician at SRH, and along with them. So what is the different thing which we practice in our NICU at Dharampur is that there are joint consultations between the pediatric super specialist and the pediatricians, because many of the babies, almost 25% of the babies, that is more than 250 babies every year we receive, they are at a high risk of developing some sort of sensory motor or some sort of developmental issues. So we have to have in like consultation with the pediatric neurologist, which is available at Dharampur. And not only that, we also have a team of pediatric super specialists, which includes pediatric orthopedician, pediatric nephrologist, pediatric cardiologist, pediatric hemato-oncologist. So all of them, they take care of each and every baby as and when needed to ensure a complete better outcome. We medical officer is also an important part of the team because he ensures that every protocol and every treatment strategy given by the treating doctor or the neonatologist is being followed in a completely better manner. And you, we also have got residents now for DCS, that is Diploma in Child Health course for CPS. So they also work as a medical officer at our setup. I think most of the district hospitals, they might have their own senior residents, or medical colleges have the postgraduates who are there in pediatrics, and they do as a duty of the medical officer to ensure the well-being of the child. Now, the role of nurses is also of utmost importance because handling the babies, positioning them throughout their stay, implementing nursing care is also very, very important. Administration of medications, then collaborating with other healthcare professional. આ બધું પણ નર્सेસનું રોલ પણ ખૂબ મહત્વનું છે. આજે બધા નર્सेસ જેટલા SNCU ના આપણા હાજર છે, તો બાળકને કેવી રીતના પોઝિશન કરવાની છે, બાળકને કેવી રીતના પેન ફ્રી આપણે જેટલું રાખીએ અને એમનું જેટલો આપણે એ કરીએ છે તે આપણે આમાં આ લોકોને કરવાનું ખૂબ જ જરૂરી છે. સો રોલ ઓફ each and every member is of utmost importance through this. Next slide, please. So this is the picture of the SRH NICU, and you can see the duty nurses and the babies who are being treated over there. Now the role of physiotherapist and occupational therapist, as we have seen, that this is of utmost importance. Like as we said, that each and every newborn who is there in the NICU at SRH is being checked for their neurodevelopmental abnormalities, and then only he is sent back at home. So every day, morning and evening, there is a team of physiotherapists and early interventionists who visit the NICU, and they teach the mothers, the caregivers, the nurses how to handle the babies, how to position the babies so as to avoid any future complications, and screen all the babies for any neurodevelopmental delays like early signs of cerebral palsy. અને જે કઈ આ લોકોમાં કઈ defect મળે છે, તો therapy is started right from day one of life. So this is Dr. Payal, who is you have seen in the videos that she was performing a lot of physiotherapy on the babies. So this is done day in, day out for the babies at NICU. And this is the comprehensive newborn screening for early intervention. So the physiotherapist, you can see, is checking for all the normal reflexes, the tone, the posture of the body of the babies. And that is how, if at all any problem is there, the therapy is started right from day one of the life of the baby. The role of ophthalmologist is of very importance. Every newborn who is admitted at SRH SNCU is screened by the optometrist for any visual abnormalities, and a clinic for retinopathy of prematurity, especially જે ઓછા મહિનાના બાળકો જે જન્મેલા આવે કે ઓછા વજનના આવે છે, they have a high risk of their retina being getting damaged. So આ બાળકો માટે આપણે ROP નું સ્ક્રીનિંગ નું પણ ઘણું બધું આપણે કામ કરીએ છીએ. And we have Dr. Valsad Sanchit, who also comes and screens these babies together. I think he is also there in the meet today. So this is the basic simple screening with the LIA paddles. As you can see that the baby is trying to appreciate the gratings on the LIA paddles. આમાં એક white અને black lines હોય છે. તો જે આપણે બાળકને કેટલું વિઝ્યુઅલ એક્ટિવિટી છે, બાળકનું આંખનું કેટલું પાવર છે જોવાનું, એ પણ આપણે એક દિવસના બાળકમાં ડેફિનેટલી જોઈ શકે છે. અને કઈ તકલીફ હોય એમને તો we can definitely start the treatment as early as possible to prevent the child from getting blind. This is the ROP screening, retinopathy of prematurity screening by the pediatric retina specialist at SNCU. And this is a very, very unique machine which is being handled by our optometrist Shama. who is especially trained in pediatric and neonatal optometry. So this machine basically tests about the function of the retina and the visual pathway. So આપણે એક મિનિટમાં જ ખબર પડી જાય છે કે બાળકના આઈસ ઓપ્ટિક નર્વ અને એમના જે પાથવે છે જે બ્રેનમાં કનેક્ટ કરે છે એ બરાબર છે કે આમાં કઈ ખામી છે. એન્ડ ઇફ એટ ઓલ ઇફ there is any problem, we can start the vision therapy or the further treatment as soon as possible. So these are the certain things which we can definitely start in our NICUs and SNCUs to ensure the well-being of the child. Now the role of audiologist and speech therapist is of utmost importance. Our audiologist Aprajita, she is doing a wonderful job, and she ensures that every child in the NICU and also the normal newborn, he is also tested for the autoacoustic emission and BERA testing. So you can see that the audiologist is performing the OAE test for the newborn, and this is the BERA screener test for the child who was admitted in the NICU. And the good part is that we can do the follow-up if the child fails this test at birth, and we do the follow-up at 1 month, 3 months and 6 months. And if at 6 months, if the child fails this test, આપણે હિયરિંગ એડના ટ્રાયલ એમને આપી શકાય અથવા તો કોક્લિયર ઇમ્પ્લાન્ટ માટે પણ આપણે બાળકને 6 મહિના પછી પણ આપણે મોકલી શકાય. કારણ કે કોક્લિયર ઇમ્પ્લાન્ટ સર્જરી ભલે આપણે ત્યાં થતી હોય પણ એ બહુ લેટ ઉંમરમાં થાય તો બાળકને આમાં શીખવાની અને બોલવાની તકલીફ પડે જ છે. એટલે that's why we want to ensure that at birth only every child is screened for audiological assessment as well. Now the role of psychiatrist and psychologist is also of very very importance in the NICU, કારણ કે સ્ટ્રેસ નું માહોલ હોય છે. બાળક NICU માં જ્યારે હોય ત્યારે ઘણી બધી વાર સિરિયસ કન્ડિશન હોય તો પેરેન્ટ્સ ને પણ સાયકોલોજીકલ સપોર્ટ છે કે એમને જે કંઈ આપવાનો છે તે બધું આપણે ત્યાં મળે છે. And we have psychiatrist Dr. Prakhar Jain, who is based in Mumbai and who is working as an assistant professor at Mumbai in a medical college. So he is the one who organizes the video sessions. And we also have got Dr. Hiren, who is also a psychologist, and he does the developmental quotient testing of each and every newborn admitted in the NICU, and also counsels the parents regarding coping up with the stress. Role of nutritionist is also very very important, because many babies who are born prematurely or they have the extremely low birth weight or very low birth weight, especially and the feeding is not properly done, it can severely affect the outcome of the child. So we have our two dietitians, Bhumika and Pooja, based in Mumbai. So they also counsel us and counsel the parents regarding the nutrition via online or whenever they are there in Dharampur. So there is also a role of obstetrician and gynecologist in in the care of baby. In what manner? That if the mother is having poor secretions, or if she has got anything like a sepsis, then her care has also to be taken. So mother and child together as a unit, they have to be considered for the SNCU. Now there is a role of certain paramedical workers like social worker as well, to understand the socio-economic background of the parents and family. અને આ બધાનું દરેક બાળકનું વિઝન આય અને ન્યુરોલોજીકલ સ્ક્રીનિંગ થયું છે કે નહીં એ પણ આ બધાને જોવાનું એક મોટી રિસ્પોન્સિબિલિટી હોય છે. અને DAIC માં પછી એમનું જે ફોલોઅપ કરવાનું હોય છે, that is also a very very important work for the social worker. Now in this photograph you can see that the health education is being given to the mothers and ASHA workers, and we certainly empower the community members, the mothers, families and the ASHA workers about the danger signs of newborns. Simple things like if we give them developmental milestones photograph chart and ask them कि પહેલું milestone 3 મહિનામાં જે head control નું neck control નું જે નહીં આવે તો તમે બાળકને ચોક્કસ લઈ આવજો. So we can prevent a lot of disabilities and developmental delays in the future. So going on to the next slide. Now this is just a depiction of the environment કે આપણે જે બધું કરવાનું છે NICU માં, કે તમે બાળક જ્યારે મધર સાથે કે ત્યાં કેર ગિવર સાથે હોય તો એમના બધા જે સેન્सेस છે, આપણે જે સેન્सेस છે, ટચ નો સેન્સ છે, સ્મેલ નો સેન્સ છે, ટેસ્ટ છે, સાઉન્ડ છે, લાઇટ છે. So we have to provide him a very very healing environment in the NICU. અને આપણા તે બહુ જવાબદારીથી કામ કરવાની જરૂરત હોય છે કારણ કે એ બધા ઉપર જ બાળકનો ફ્યુચર ઇઝ ડિપેન્ડન્ટ. સો વી હેવ ટુ ટેક કેર અબાઉટ ધ પોઝિશનિંગ એન્ડ હેન્ડલિંગ ઓફ ધ બેબી, કે વોટ ઇઝ ધ કરેક્ટ પોઝિશન એન્ડ હેન્ડલિંગ વે. વી હેવ ટુ એન્શ્યોર ધ સ્લીપ, કારણ કે બ્રેન ગ્રોથ માટે સ્લીપ ઇઝ વેરી વેરી ઇમ્પોર્ટન્ટ, અને સ્લીપ બાળકની જે અફેક્ટ હોય તો વી આર અફેક્ટિંગ હિઝ ફ્યુચર ફોર શ્યોર. મિનિમાઇઝિંગ ધ સ્ટ્રેસ એન્ડ પેઇન ઇઝ ઓફ અટમોસ્ટ ઇમ્પોર્ટન્સ. બાળકને ઘણી બધી આઈવી લાઈન હોય, ઇન્જેક્શન્સ લાગેલા હોય છે, સો વી હેવ ટુ એન્શ્યોર કે બાળકને સેલ્ફ રેગ્યુલેશન મિકેનિઝમથી અને હેન્ડલિંગ મેથડ્સથી પેન કેટલું ઓછું કરવાનું. ઓફકોર્સ વી કેનોટ રિડ્યુસ ધ પેન ટુ 100%, બટ મિનિમાઇઝ કરશે તો આપણે વી કેન રિડ્યુસ ધ ઇમ્પેક્ટ ઓન હિઝ બ્રેન ડેવલપમેન્ટ. પ્રોટેક્ટિંગ ધ સ્કિન, optimizing the nutrition, and of course partnering with the families. So these are the 7 core principles. આ આપણા 7 પ્રિન્સિપલ્સ છે કે બાળકને પોઝિશનિંગ, હેન્ડલિંગ, એની સ્લીપ બરાબર આપણે રાખવાની હોય છે, એનું સ્ટ્રેસ અને પેન આપણે ઓછું કરવાનું છે, એનું સ્કિનનું પ્રોટેક્શન કરવાનું છે, એને ન્યુટ્રિશન ઓપ્ટિમમ રીતે આપવાના છે, અને ફેમિલી સાથે આપણે આ બધું કમ્યુનિકેશન આપણા આખી ટીમને ચાલુ રાખીએ આપણે, તો ડેફિનેટલી આપણું જે આઉટકમ છે તે નોટ ઓનલી અ ડિસ્ચાર્જ બેબી વિથ અ ગુડ વેટ, but also a baby who has a potential to develop into an intelligent human being. I think એ આપણે બધું આમાં સ્ટ્રેસ કરવાની જરૂરત છે. અગેન a little bit about the comprehensive family support in the NICU, કે આપણે આમાં ફેમિલી સેન્ટર્ડ કેર, કે મધરને પણ ઇન્વોલ્વ આપણે આમાં રાખવાનું છે, કારણ કે મધરનું અટેચમેન્ટ આપણે જોયું જ છે કે મધર સાથે બાળક અટેચ હોય તો એની હીલિંગ પણ ફાસ્ટર થાય છે અને એમના બ્રેન ગ્રોથ પણ સારી રીતના થાય છે. આમાં વી હેવ ટુ ટેક હેલ્પ ઓફ મેન્ટલ હેલ્થ પ્રોફેશનલ્સ, દેન ફેમિલી સપોર્ટ, પિયર સપોર્ટ ગ્રુપની વાત કરીએ, પછી જે કોઈ બાળકોને બહુ કઈ ગંભીર તકલીફો હોય તો એને પેલિએટિવ અને બિરીવમેન્ટ કેર પણ આપણે આપી શકાય, અને સ્ટાફ એજ્યુકેશન અને સપોર્ટ ઇઝ ઓફ અટમોસ્ટ ઇમ્પોર્ટન્સ, અને ડિસ્ચાર્જ પછી બાળકનો ફોલોઅપ એન્ડ કમ્પ્લાયન્સ ઇઝ ઓલ્સો ઓફ વેરી મચ ઇમ્પોર્ટન્સ. નાઉ આમાં જસ્ટ એક ક્વોલિટી કેર ઇન એનઆઈસીયુ આપણે કેવી રીતના કરવાનો છે એના ઘણા બધા ફ્રેમવર્ક્સ આપણે પાસે છે. એક તો છે કે આપણે ફિઝિકલ એન્ડ કલ્ચરલ એન્વાયરમેન્ટ કેવું રહેવો જોઈએ, કે એઝ મેન્શન બાય ધી પ્રીવિયસ પ્રેઝન્ટર્સ, કે ફિઝિકલી આપણે એમાં બહુ વધારે સાઉન્ડ ના રાખીએ, બહુ વધારે લાઇટ ના રાખીએ કે બાળક ઊંઘી શકે બરાબરથી. કમ્યુનિકેશન ટીમની વચમાં કેવું રાખવાનું છે, ઇવન ફોનની રિંગ કેટલી રાખવાની આમાં એનઆઈસીયુમાં ફોન હોય તો દેટ ઇઝ ઓફ ઓલ્સો વેરી ઇમ્પોર્ટન્સ. તો એને જે એન્વાયરમેન્ટ પ્રોવાઈડ કરવાના છે એ એકદમ હેલ્ધી અને એમને સપોર્ટિવ એન્વાયરમેન્ટ આપણે પ્રોવાઈડ કરવાના છે. સેકન્ડ થિંગ ઇઝ અબાઉટ ઇમ્પ્રુવિંગ ધ કલ્ચર, કે આપણે આમાં ઇમ્પ્રુવમેન્ટ કેવી રીતના કરતા છે, કે ફ્રન્ટલાઈન સ્ટાફને કઈ આપણે આવે તો એને કેવી રીતના સપોર્ટિવ સુપરવિઝન આપવાનો, કોઈ સારો પ્રયત્ન કરી રહ્યા છે નર્સ કે ડોક્ટર તો એમને એપ્રિશિએટ કરવાના, સો દેટ એ લોકોનું મોરલ સપોર્ટ પણ વધશે. અને છેલ્લે છે કે ઓર્ગેનાઇઝેશનલ કન્ટેક્સમાં કે આપણે એડમિનિસ્ટ્રેટિવ સપોર્ટ કઈ આપવાના છે તો આપણે એમાં પણ ક્વોલિટી ઇમ્પ્રુવમેન્ટ અને સ્કિલ સપોર્ટ આપણે આપી શકાય. લાસ્ટલી ધ હોલ થિંગ ઇઝ અબાઉટ કમ્યુનિકેશન, ધ ટીમ વર્ક, ફેમિલી ઇન્ટિગ્રેશન, અને આ બધી પ્રોસેસ જે આપણે સ્ટેન્ડર્ડાઇઝ કરીએ તો ડેફિનેટલી આપણું આઉટકમ જે છે બાળકનું તે બહુ સરસ રહી શકે છે. આપણે ફેઝ 1 જે આજની ટ્રેનિંગ હતી આમાં આપણે આ બધું જોયું છે આજે, કે સેલ્ફ રેગ્યુલેશન, ન્યુરોપ્લાસ્ટિસિટી, epigenetics, and a role of team members in the NICU SNCU. Phase 2 ma we will be taking more about the practical implications of the normal abnormal development, normal IUGR growth, kangaroo mother care, and importance of feeding and olfactory systems, and this will be more of a practical based training. So છેલ્લે મને એ જ કહેવાનું છે કે NICU માં team is together everyone achieves more, and I think with today's presentation each one of you has got an idea કે આપણે બેસિકલી એક સેફ એન્વાયરમેન્ટ, એક હેલ્ધી વેમાં ટીમ મેમ્બર્સને સાથે મળીને ઇન્ક્લુડિંગ ધ ડોક્ટર્સ, ધ નર્सेस, ધ ફેમિલી સપોર્ટ એન્ડ પેરામેડિક્સ આપણે બાળકનું વેલબિંગ એન્શ્યોર કરવાનું છે. So thank you so much. That is what we wanted to say, and I think if somebody is there from SIHFW or any questions we can take forward.
Sir, there are few questions in the chat box.
Yeah.
So we have a slide for it, sharing from here.
Okay.
It's being Yeah. So there was a question for the role of a dentist in the DEIC team. Yes, dental department is extremely important, and we have a outreach dental van which takes care of this, as well as we have parental counseling for pregnant women for dental hygiene and dental care. And our DEIC Dharampur team has Dr. Vaishali Kamdar, who's been taking care of the dental department. So yes, it's important for us to do a parental counseling for pregnant women, and very important, and it's part of the DIC, compulsory part of the DIC team. So thank you, Dr. Bimchi, for that question, and we can take care more questions, sir. Dr. Gorage.
Yeah.
So if someone wants to say something or how.
Yeah. I think there is one more question, that can expression of genes be changed if the triggering factors are modified? I think that needs a little more
clarity. Yeah. So I will just ask Dr. Bansi to come here and talk about it.
Sorry, can you just can the expression of genes be changed if the triggering factors are modified? If the gene is not expressed, yes, then definitely that's what we are going to do by not letting the gene to express. And even if it's expressed, for example, say autism or whatever, then we have to manage the disease in the best best possible functional outcome that we can give the person. But we are working towards not letting the gene turn on. If that autism gene turns on, then we want to prevent those factors which turn this gene on. Okay, so we as therapists, as working on the mothers, working on the environmental factors in the NICU, doing self-regulation. That's what we're doing. We are allowing not those genes to express postnatally in that child, so that they don't have all these big ASD features and stuff like that. And also prenatally on the mothers, so that they are stress-free and everything, so that they are not having those babies express the genes.
Yes, so that's very important, because it's on us as therapists, as professionals in the NICU, whether to let the genes stay dormant or whether to, switch it on. So it's a huge responsibility that we can make a change in the DNA of the child by giving it the right approach at the right time. So that was a wonderful question.
Yeah. And to add to this thing, in one of the presentations we saw that in the famine, because the child, the mother had poor nutrition, and that had effect on the gene. So I think definitely if we provide proper nutrition, over the time period, the genes will also change. So this has been proven by science and experiment. So I think that sums up the thing. And I would also like to mention that all the pregnant ladies who come in the hospital at SRH, they are being treated by the dentist. They are seen by the dentist. Although I didn't include it in the part of the NICU team per se, but because we realized that having good oral hygiene and ensuring dental health and oral health will definitely lead to a better outcome in the child, because many studies have proved that having poor dental hygiene in pregnancy is definitely leads to a lot of defects, even congenital heart defects. Some of the studies they say. So definitely, Dr. Bhimshi, the role of dentist is of utmost importance, and you can start screening the mothers, expectant mothers, for the dental problems and treat them on a timely basis as well. So thank you all. I think if somebody from Gandhinagar or SIHFW, if they want to conclude, if they are there, Pradyuman Bhai, Rathod sir.
Thank you, Gurji bhai, and your whole Shrimad Rajchandra team to give a nice orientation about the role of all the DIC staff as well as the physiotherapy and all the staff of SNCU in the SNCU, how to take care of the small babies, and it makes a lot of sense to, and it will give a long message to all the SNCU staff and who are the present in the webinar. We'll surely arrange for phase 2 also, as some so Pankaj Bhutt sir has already said that when is phase 2. But on the today's session, we will plan out for post Diwali for the phase 2.
Surely, surely.
Yeah.
So, sir,
all-
there was a question.
Yeah, please.
Yeah.
Relaxation techniques for ADHD patients.
Yeah. So a huge question. I think it's very, very important to know what are the techniques to treat an ADHD child. But for that, we need to really understand what's going on wrong with them. So we have a special evaluation where we do a sensory evaluation as a total up, like we see where the systems are missing, whether the systems are hyperactive or hypoactive. So depending on that, which system to work on. So there are no techniques as such because we need to really first do a thorough evaluation of the sensory systems like the vestibular system, the tactile system, the proprioceptive system, and see in that whether it's causing what is causing the child to do a hyperactivity. Is it the tactile defensiveness where the child is not able to take a person's touch and just running all the time? Because of that, is he dysmodulated, or is this because of some vestibular system where he's not able to know movement? So he's constantly running all over the department where you don't know what to do, and as therapists we keep running up behind them. So it's very important to know the sensory aspects of the child as a total first with the evaluation. So when we go in the phase 2 and phase 3 and all, we'll be definitely covering that part. It's a huge topic, and it would require a few hours to finish it. So thanks for that question. And there's another question: if child does not develop some part of brain in womb, then how to work on the neural plasticity and make change in the child? So again, very important. So the development in the womb of the brain, in the womb happens. So in that, the brain is developing constantly. So there is a possibility where the child has gone intrauterine growth retardation, or child has got some damage in the intrauterine environment. So in that, the other part of the brain is going to take up the function, and that is what neuroplasticity is all about. If one part, if you remember that picture which Dr. Neha had shown, if that one part of the brain that is missing, then the surrounding areas of the brain learn to take up the function. But for them to learn to take up the function, it's very important that you teach them the function, and teaching them early means you have got that function correctly at first years of life. So again, it's beautiful that you'll have thought about the neural plasticity part of it, and that will help us because that science is so nice that the brain is still moldable. It's like a clay, you can shape it the way you want. So that will become important, and that techniques at the right time will help it. Like Dr. Neha, can I add something?
When I said that, if you remember, 85% of the brain develops postnatally. So there are beautiful chances that the brain will develop afterwards. So even if the part is missing, then when the child is born, there is a 85% chances that the other part of the brain or the cortex will take over those functions as well. So with the repetitive movements, with giving them the environmental stimulation, plus giving them the secure attachment and everything, all these things are possible.
And that was the purpose to add the science behind early intervention today. That is why we wanted you all to first know the importance of what factors are taking place when they come in the NICU, what factors are leading them there. Before NICU stay, what happens to them in the epigenetic part of it. And then self-regulation after their entire discharge and during the time in the NICU. So that is why this purpose of taking these topics was this, that what is the science behind this entire concept of early intervention? Yeah. So I think we are done with the questions. So Dr. Gaurav, you can.
Yeah. I think we have done up with most of the questions. Now everybody is, I think, eager to know about the second phase, but I think we'll be coming up with that after Diwali, post Diwali, as Dr. Pradyuman has also said. So I hope that everyone has enjoyed that thing, and everyone has liked. I think there is one more question.
One more question, if you can.
Paraplegia, as is operated for NTD, can we use deep tactile stimulation using a physio ball? How many times and how exactly can we do? Ben.
Yes. So NTD operated for NTD. Can you just give me the full form?
Neural tube defect.
Okay. So any kind of spinal defects in the this thing.
Yeah.
Okay, yeah. So so again a huge role of tactile stimulation as such. Again, we do not look at stimulation right now when he's been operated, and we look at more of function, and in that we need to integrate both the motor and the sensory part of it. So you will look at both. You look at motor part of it and sensory part integrating. We do not look at stimulation specifically because stimulation has to do only with one, you're constantly giving that input. But for what? We need a function. So we need to work in a function. So when you look at function, says the child wants to stand or the child wants to sit after a post-operative intervention, then we need to first work on where the level of the spinal cord damage happened. What are the things where we can, it's most to do with the lower motor neuron lesion. So we look at it differently than looking at it at a brain function. So it's not specifically he might have few upper body movements which are already taking place. So we'll also see the development. We'll not only see whether the legs are moving or not, whether the stimulation is happening or not of the legs. It's very important that he overall develops, because one part of the body is not, it's not one part of the body which gives you function, right? It's the entire body with the brain, with the central nervous system, which gives you function. So you look at more functional goals with them, and the techniques then would depend on that goal. So very important that we need to know how to deal with it. So we can cover that surely. There is one more question.
Regarding that, I would like to say that we can also provide algorithms for all these things later in the later phases of the training, where for early intervention, if a child comes like this, what we can do. So it becomes very clear for the caregiver.
Yeah. So our topic today was more to do with the NICU part. So we've not really covered that area. Yeah, I'm a physiotherapist. Proud to be a physiotherapist. Because physiotherapy can do wonders, and we've seen that. So we are very happy to have that profession. Yeah, Dr. Maitri, that's really good that you're happy to be a therapist, and we can do a huge lot of difference. We are underused, so just take that up, and we can do wonders in the NICU, post care, rehabilitation, everything.
Just to add on, myself also a physiotherapist.
Yeah, Dr. Pradyuman is also a physiotherapist.
I'm so
He's
happy.
managing
the therapy bond.
Okay, so we can end the session for today, and we'll join again for second phase in later on stage. Okay.
Absolutely.
Yes, sir.
Thanks the whole team.
So
Thank you so much.
From SNCUs Gujarat. Dr. Upadhyay is on to valedictory session that is in the training that is going on right now. So I'm just going to say a vote of thanks. Thanks to Shrimad Rajchandra Mission, RBSK team, Health Department, Government of Gujarat, and all the participants who actively participate in this session webinar. I'm gonna end this session now. We have recorded the session, so if all these things going smoothly, then we will have uploaded it in our channel, YouTube channel. They can review it later on.
Yeah. Anisha Ben, our trustee Dr. Mehta wants to say something. Dr. Tina Ben, just for 2 minutes if you allow.
I just
No,
want
no,
to thank everyone.
Please,
I
please.
want to thank the Gujarat government, SIHFW Gujarat also, and all the participants and all the attendees to give us a nice opportunity to present our work and our experience in front of all of you. Thank you.
Thank you so much.
Thank you.
Thank you. Bye.
Okay, I'm gonna end the session now.